realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80+ APIs, 350+ formulations, and 175+ brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout the summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout the summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. Ipca Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. Ipca, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At Ipca, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. Ipca is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. Ipca has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA and Sunderland, UK. Ipca's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80+ APIs, 350+ formulations, and 175+ brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. Ipca has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities Conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities Conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. IPCA is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. IPCA has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80+ APIs, 350+ formulations, and 175+ brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout the summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. Ipca is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. Ipca has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. Ipca's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. Ipca has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. Ipca Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. Ipca, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At Ipca, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest technology and staffed by a team of dedicated experts committed to pushing the boundaries in various therapy areas. Ipca is the largest manufacturer and supplier of many APIs and formulations across the globe through its world-class manufacturing facilities and research and development techniques. Ipca has a wide network of manufacturing units in India and across the globe, including our API manufacturing facility in North Carolina, USA, and Sunderland, UK. IPCA's global footprint is reflected in our wide array of formulations offered across the world. Over 350 formulations covering every dosage form, we ensure high-quality standards at our formulation manufacturing facilities. Today, we manufacture and supply 80-plus APIs, 350-plus formulations, and 175-plus brands in more than 120 countries across the globe. We are the global leaders in malaria management and pain management. We are expanding our wings globally in therapies like rheumatology, dermatology, neurology, ophthalmology, diabetology, cardiology, and many more. IPCA has always been at the forefront of cardiac care in managing hypertension, heart failure, dyslipidemia, preventing heart attacks, or treating arrhythmias. Globally, we are the largest manufacturer and supplier of cardiac APIs and formulations such as beta blockers, ARBs, and diuretics. The real measure of our success lies in the lives we touch. Through our innovative medicines and therapies, countless individuals have gained their health and vitality. The Global Summit on Hypertension and Comorbidities conference serves as a platform for us to come together, share knowledge, and explore innovative ways to address the challenges posed by hypertension and its comorbidities. Together, we have the power to transform lives and make a lasting difference in the world of healthcare. So, let's embrace this opportunity to connect, learn, and collaborate. Let us fuel our passion for excellence and innovation. In this gathering of brilliant minds, we embark on a collective journey to improve the lives of millions affected by these conditions. Throughout this summit, we will engage in thought-provoking discussions, gain insights from renowned experts, and learn about cutting-edge advancements in the field of cardiometabolic management. Welcome esteemed doctors and healthcare professionals to the highly anticipated medical conference on managing hypertension and comorbidities. In the realm of healthcare, where every heartbeat matters, there's a silent force working relentlessly towards making the world healthier. IPCA Laboratories, a pioneer in pharmaceuticals dedicated to improving lives. IPCA, a consumer-led global pharmaceutical company creating healthy doses of life since 1949. At IPCA, innovation fuels our mission. Our cutting-edge research facilities are equipped with the latest
Goa. This year, this global summit is hosted in affiliation with the World Hypertension League, European Society of Hypertension, and Indian Society of Hypertension. I'm Pallavi Shetty, and it's my great honor to be a part of this prestigious summit once again. I'm delighted to see so many familiar faces as well as new ones, all gathered here to share their invaluable knowledge and insights. This summit is a fantastic opportunity to learn, collaborate, and advance the understanding on hypertension and its related conditions. While you dive into these important discussions, let's also take a moment to enjoy the stunning surrounding of Goa, known for its breathtaking beaches and vibrant culture. I'm sure it is the perfect backdrop for both professional growth and relaxation. Thank you once again for being here, and let's make this incredible journey amazing for all of us. May I now invite Mr. Johnny Edwin, Vice President, IPCA Laboratories, for his welcome address.
Good afternoon, doctors. It's indeed my great privilege and honor to welcome you all on behalf of IPCA Laboratories Limited for this Global Summit on Hypertension and Comorbidities. The overwhelming support and the response that you have been giving to us has always been making us more challenging every year. How do we make it better than what it was earlier? And this is the Global Summit on Hypertension and Comorbidities 6.0. This is the 6th year that we have entered into the summit, and we started in 2016, of course, under the able guidance of Padma Shri Professor C. Venkateswaran sir, with all his knowledge, wisdom, for the almost close to 5 years in the field of hypertension, which he has imparted to us, and with which we are able to make this summit better every year in terms of scientific, in terms of the other aspects as well. After the 3rd year onwards, and the suggestions from doctors, you all, because this was only the some hypertension summit, it was coined as Hypertension Summit when we started. Then after that, with all the suggestions, we included the topics on comorbidities as well. And of course, under the guidance of Dr. Ram sir, we went globally by inviting the foreign faculties as well. And the name was coined as Global Summit on Hypertension and Comorbidities. So that's where it went from Hypertension Summit to Global Summit. And maybe one of the conferences which you all would be knowing much better, which is more focused on hypertension-related disorders as far as this Global Summit is concerned. This year, of course, it's been a great honor and privilege. Every year, of course, World Hypertension League has been one of the integral part of a summit which moves under guidance. We have been moving ahead since Ramsar shifted to India. From that onwards, IPCA's collaboration with World Hypertension League was strengthened year after year, year after year. And this year, again, every year, of course, and we have Dr. S.N. Narsingan, who is the Vice President of the World Hypertension League. Again, his support with regard to the World Hypertension League and IPCA's collaboration, both in academic initiatives as well as in the public front, has also taken to the next level. And we are also grateful to have the European Society of Hypertension, which is affiliated, which gave their consent to be affiliated with this Global Summit of Hypertension. And we have Professor Manchia sir, who is the founder of the ESH, and Dr. Grassi, who is again the president of the EHS Scientific Committee here. So it's an honor to welcome both of you, sir. It's an honor for us. And we also take this time and honor to all the scientific governors and who have been an integral part of this scientific agenda which you're seeing, because it was the late night hours when this started, when the discussion started on this agenda. We are grateful to Dr. Rabin Chakravarti sir, Dr. H.K. Chopra sir, Dr. Tiny Nair sir for all their contribution, and Dr. Nakul Sinha sir when making this scientific agenda more interesting and more valuable. So we are honored. We also take this opportunity to welcome Dr. Rajiv Gupta, who is the president of the Indian Society of Hypertension, who again has been the ISH also for the last few years, have been associated with a lot of initiatives on terms of public front as well as on the academic front also. So that's where this summit is happening with all the support of these governing bodies. And we at IPCA also, apart from these academic initiatives, we are more focused on a new initiative was the Cardio-Kidney Metabolic Connect, which we initiated after the ASH talked about the CKM syndrome. So from then on, we also have initiated on CKM, and we are planning to create some clinics on CKM across the country. So that was one of the initiatives, which of course, doctors like Dr. Chopra sir and all have been associated and been guiding us in this regard. We also are interested, again, heart failure is again an emerging aspects in the current scenario. So we were looking at, okay, can this be reaching to all the places across the country? So one such initiative is about the heart failure clinics. Wherever possible, we wanted to take up this initiative of creating heart failure clinics, as well as the chest pain clinics in collaboration with the STEMI Association of India, where we wanted to create some awareness, both on the public front as well as creating a need wherever there is a requirement. So these are the few initiatives from IPCA laboratories which we are looking forward. And we always value your support, your guidance, and every support of yours has been strengthening us to grow and give the best for this global summit. And at this juncture, I also take this privilege and honor to welcome our Mr. Sunil Gai, our President Marketing for the domestic operations of IPCA Laboratories. Over to you, sir, for your words.
Once again, very good afternoon. And on behalf of IPCA team, I take this opportunity to welcome all the delegates to Global Summit on Hypertension, Comorbid 6.0 and at Goa. And a very warm welcome to our course director, Dr. C. Venkatram, co-director, Dr. Robin Chakravarti, and the scientific governor, Dr. Nakul Sinha, Dr. Samir Dani, Dr. Chopra, Dr. Narsingan, Dr. C.K. Ponde, Dr. Sarita Bajaj, Dr. Ajay Mahajan, and Dr. Tanni Nair. Every time when we go to your clinic, we talk about products. I thought at least give a little brief about what about IPCA. Doctor, at IPCA, we are not only in the trading of and manufacturing of medicine. Our philosophy is to do our business through a very scientific promotions, participating and conducting big scientific programs. We have conducting this hypertension summit since 2016. This is the sixth one. And this all I'm very happy to share with you. This is very successful. The number of delegates are increasing year after year. And this is show that there's a good scientific content, because for you, the science is more important than the hospitality. And we are also want to share with you that IPCA have almost 28 manufacturing plants. Most of the plants are approved by the most prestigious agencies like UK MHRA, US FDA, TG Australia. And we operate almost in 120 countries. And we are operating in both developed and undeveloped countries. Moreover, doctors, we are into, when you see an Indian scenario, in addition to this, we are also having a big field force to address most of the needs in the marketing, on 9,000 people. We have 20 verticals, and I am very happy to share with you, because of your support, now in cardiac diabetic, we have almost five divisions, and a cluster of 5 divisions. And if you see as how the IPCA perform in the market, because most of people are nowadays aware about how the performance has compared to others. In the last 10 years, we moved from 26th rank to 16th rank. We are the topmost on a growth parameters. And when you see about the cardiac, we also moved from 18th rank to 15th rank. Once again, thank you very much for your support. Our last 6 years has a significantly increased in the contribution of our prescription from specialists and super specialists. I always feel proud and thankful for every doctor to make IPCA an undisputed leader in pain segment, rheumatology and antimalarials, and a very prominent player nowadays in cardiac, diabetic, derma, uro, and CNS. And once again, a big thanks for making an iconic brand like CTD. Our endeavors are consistently directed towards advancement of scientific knowledge. IPCA Medical Department has accomplished its exceptional work in the field of diabetes research, following the extensive clinical trial, and we have successfully obtained the patent in the use of hydroxychloroquine sulfate in the type 2 diabetes. And now we are launching another patent products in diabetic foot ulcers that we probably will launch in the month of September. And we are moving very forward towards more specialized products. Considering all these things, doctor, once again, I'm thankful for everyone for sparing this time and come all the way to Goa. Thank you very much.
So, welcoming you all once again on behalf of IPCA Laboratories Limited. It's my great honor and to welcome Padma Shri Dr. C. Venkatesh Ram sir, who has been instrumental for the summit right from the beginning, the brainchild of the summit. Dr. Ram sir has been, all of you know, of course, but still to mention here, was the director and academic scientific affairs of the Indian Society of Hypertension. He is the professor of clinical medicine, University of Texas, and also director, Texas Blood Pressure Institute, and the personality who has been dedicated for the hypertension therapy per se for almost close to 5 decades. So over to you, sir. We welcome you. And I request Mr. Sunil Gai, sir, to honor Venkat Ram, sir.
Good afternoon, ladies and gentlemen. I will save my remarks for the evening inaugural event. I will stick at this moment to the scientific part of it, and in the evening I will tell you what has happened in the last 9 months to create this summit. So let's move forward with the scientific program right now. And the way it has been designed with the help of the scientific governors is we have a session co-director for each session. And there are 3 clinical scholars for each session, 3 or 4, who will conduct the proceedings of each scientific session. The session chair has an immense responsibility of keeping the time of every speaker because it's a very compact program, and I strongly advise and ask the speakers to please maintain your time so that we have time for panel discussion, which is always the best part of any scientific program. So ladies and gentlemen, with those remarks, I would now ask Dr. Rabin Chakrabarty to walk towards the podium. And Dr. Rabin Chakrabarty is the co-director of this Hypertension Summit, and he has participated in our Zoom meetings, in our personal meetings, to come with the scientific agenda, and I'm very thankful to him for helping me to come to this level of the summit. Dr. Rabin Chakrabarty, we always say that he does not need any introduction, but as a formality, introductions are needed, in my opinion. Dr. Rabin Chakrabarty is one of the most senior cardiologists in the country. He is a graduate of Calcutta Medical College, and then he did his MD and DM at PGI Chandigarh, and then he returned to Calcutta, and he has served in various academic institutions in Calcutta as a clinical cardiologist, as an electrophysiologist, and importantly, training a number of young doctors in cardiovascular medicine in Calcutta. At the present time, he's a senior vice chairman, head of cardiology services, and chief electrophysiologist at Manipal Medical Group of Hospitals. He has a number of accolades with him and behind him, which are already there in the printout that you received. So he is going to discuss with you. He's going to be chairing this particular session. He is going to introduce the clinical scholars. Then I will introduce the panelists for the session. So Rabin, please take over.
Thank you, sir. Thank you very much. And it's a privilege and honor for me to be here once again, like every year. And I think before we introduce the scholars of these sessions, and just we need to understand about the scope of the session, what Dr. Venkatram has really sincerely, with a lot of commitments, had made this program. Can I have my just take 2 minutes to just to elevate the status of the meeting and also to keep ourselves updated. Can I have the first slide? The scope of the meeting. So this is basically, as we said, the Global Summit on Hypertension and Comorbidities, and it has been clearly explained that why it is comorbidities. And if we move further, we know that hypertension is a serious medical condition. It is a global public health challenge. Hypertension does increase the risk of heart, brain, kidney, and other diseases. It is a major cause of premature death worldwide, with upwards of 1 in 4 and 1 in 5 women, over 1 billion of people having this condition. The burden of hypertension is progressively increasing. It is not only the most common, but also one of the most important modifiable risk factors of coronary artery disease, stroke, congestive heart failure, chronic kidney disease, and peripheral vascular disease. The positive relationship between blood pressure and the risk of vascular disease is strong, continuous, graded, consistent, independent, and predictive, and etiologically significant for those with and without previous history of cardiovascular disease. Furthermore, the randomized controlled trial have clearly demonstrated that therapy, antihypertensive drug treatment reduces vascular disease incidence and mortality among patients with hypertension. Worldwide, more than 1 billion people are victims of hypertension. Hypertension is costly to the global healthcare system. It has been shown that global direct medical cost of non-optimal blood pressure is nearly 370 billion for the year 2021. It was 2021 and 22. The cost represents about 10% of the global healthcare expenditure. The main barrier is a lack of awareness and realization of the importance of treatment, therapeutic compliance, and thereby blood pressure control. Keeping these in mind, Professor Dr. Venkatram very thoughtfully designed a meticulous program for the summit. His untiring endeavor in the selection of topics for this meeting is to revisit, redefine, and relook at hypertension in 2024. I'm sure take-home messages will be meaningful and extremely pertinent for all of us in our everyday clinical practice, and our patients will be benefited tremendously from their disastrous consequences of uncontrolled high blood pressure. Finally, I acknowledge the sincerity and commitments of IPCA laboratories for this cause by arranging this program every year by collecting nearly 800 physicians from all over this country, along with illuminated faculty members. Thank you very much. With that small introduction, may I now request the scholars of the first program, Professor Dr. Nakul Sinha. He is a past convener of NIC, of our National International Council of Cardiological Society of India. He is a fellow of American College of Cardiology, fellow of Society of Cardiac Angiography Intervention, fellow of Indian College of Cardiology, fellow of Cardiological Society of India, fellow of Asia Pacific Society of Interventional Cardiology. He is a Commonwealth Fellow in Interventional Cardiology in UK, 1993-94. He has more than 150 research publications, review, editorial, and book chapters. He has been a principal investigator of more than 52 clinical trials. Professor Nakul Sinha. And the next is Dr. Mohan Lal. Dr. Mohan Lal is a renowned cardiologist of the northern part of India. He is an ex-professor and head of the Department of Cardiology at GMC Jammu. He is ex-cardiologist of King Faisal Hospital, Saudi Arabia. He has fellowship of Leeds University, Yorkshire, England. He is a fellowship in interventional cardiology at Scott Hospital, New Delhi. He experienced cardiology of 40 years, faculty medicine, Government Medical College, Jammu, ex-MCI inspector in cardiology. He chaired national and international cardiology meetings and special interest in clinical cardiology. But I think with me, it is very important for me to declare that Dr. Mohanlal was my senior registrar when I was doing MD in PGI Chandigarh, Dr. Mohanlal. And Dr. Kiran Varghese, past president of Cardiological Society of India, Bangalore, past organizing secretary of Annual Conference of Cardiological Society of India, Karnataka chapter. He has more than 50 publications in national and international journals. He is author of book Therapeutic Embolization and writing chapters in book Pulmonary AV Fistula, delivered numerous guest lectures and invited lectures at various conferences. He is investigator and co-investigator for numerous national and international fellows. So with this renowned 3 scholars, we can probably start our first session. Dr. Venkatram.
So, ladies and gentlemen, the way the structure is, we'll have panelists for both the sessions. If they can come to the stage and then they can go back to the audience, and during the discussion they can come back to the stage. Dr. Sanjeev Indurkar, who is an old friend of mine, is a very senior physician with interest in cardiometabolic disorders, and is a wonderful name in Aurangabad, in Marathwada. He is a highly respected figure in Aurangabad. They conducted various clinical trials and various publications. So he is going to be one of our panelists. Please welcome Dr. Indurkar. The next panelist is Dr. Kashinath Ghosh Hazra. I saw him coming in. Please come to the podium. He's a senior consultant cardiologist in Calcutta. He's a member of DNB courses, and he has conducted postdoctoral fellowship programs for a number of students. And he's a member of American College of Cardiology, European Society of Cardiology, and a senior member of API. So he will be a very important part of our panel, brings a very broad spectrum. Then my old friend, actually he's young, everybody's younger to me, right? So Dr. Santosh Salagre, he's always Santosh, he's always happy. So good to see him. Santosh Salagre is one of the few people that I know who has dedicated his career to hypertension. He runs a hypertension clinic at the KEM hospital, a very well-known senior physician, and he's trained a number of residents and fellows, and is totally dedicated to management of hypertension and well-known. Dr. Jayashilan, I saw him, I thought, yes. Dr. Jayashilan is a staff member and a senior member of Jayadeva Institute of Cardiovascular Sciences and Research. Jayadeva Institute is a name to reckon with. He is a member of the American College of Cardiology, a number of publications, and he is both clinical cardiologist, prevention, as well as interventional cardiologist. He is going to be on the panel. Dr. Sanjeev Gulati, I met him just, Sanjeev, He's current president of Indian Society of Nephrology. I always believed that kidney is the heart of the matter for cardiovascular disease. If you have good kidneys, your cardiovascular health is good, and vice versa. He's Indian Society of Organ Transplantation. He worked in Hamilton, Canada. I don't know whether he worked with Salim Yusuf. I presume he did with Salim Yusuf. And his number of transplants, kidney transplants in the country have taken place under his guidance. So ladies and gentlemen, we have panelists representing different disciplines, ultimately converging into the prevention of cardiovascular disease through cardiovascular risk factors. Now, I'll ask Dr. Abhin Chakravarti to start the proceedings and start the program.
Thank you very much. I think with that introduction, we are straight away going to start the session. The first speaker, Dr. Rajiv Gupta, he is going to talk to us on hypertension-mediated morbidity and mortality, implications for India. Dr. Gupta. Yeah, we'll just, if you could stay for just, Dr. Can I have it quickly? Can you introduce Dr. Gupta?
All right, so I'll request all the speakers to be seated only. We'll be introducing all the speakers first and then we'll be calling them for the presentation.
Sure, I think that is a good idea. Yeah, we can introduce all of them first. So can you just show the introduction slide? And Dr. Gupta is the president of Indian Society of Hypertension, member of Project Approval Committee, ICMR, honorary professor of Mahatma Gandhi University of Medical Science and Technology, distinguished scientist, Birla Institute of Scientific Research, Jaipur, chair, Center for Development Communications, NGO, Jaipur, pioneer in cardiovascular epidemiology in India, 1,100 scientific publications, 700 original articles, reviews and major journals, 125 book chapters, 9 books, 202,000 citations at Google Scholar, ranked top 0.1% global scientist, first in India, 108th globally in his field by Stanford University ranking algorithm. Board members of World Heart Federation created models for low and middle income countries for prevention of heart disease. His many research and academic awards to his credit. Dr. Rajiv Gupta. And next to him is Dr. A.K. Panchali, Aditya Panchali, is a good friend of mine. Dr. Panchali, if you could come forward. Dr. Panchali is an organizing secretary of first CSI Heart Failure Conference at Indore 2015. I remember this. Recipient of BC Roy Award by MPIMA, recipient of Charak Award by MPIMA, recipient of Excellence in Cardiology Award by National Indian Medical Association, recipient of Special Award by Association of American Cardiologists of Indian origin in Chicago 2012, speaker in European Society of Cardiology Congress, London 2015, speaker at World Congress in Cardiology 2014, Melbourne, and 2016 Mexico, and 2018 Dubai, ex-associate editor Indian Heart Journal, currently convener of Preventive Cardiology Council of Cardiological Society of India, regularly writing chapters in the textbook of cardiology and cardiology updates. He has 65 publications with 40 chapters in textbooks and cardiology update book. Dr. Aditya Panchali. Next, Dr. Giuseppe Mancia. Dr. Mancia Dr. Mancia, if you could stand here there. Dr. Mancia is Professor Emeritus at University of Milano Bicocca, former Head Department of Internal Medicine, University of Milano Bicocca, President European Society of Hypertension Foundation, Chairman of European Society of Hypertension Educational Board, past President, International Society of Hypertension, European Society of Hypertension, European Society of Clinical Investigations, Italian Society of Hypertension, Chairman, Consultant of Italian Scientific Societies for Cardiovascular Prevention, highly cited research in clinical medicine, Dr. Mancia. And can I call now Dr. Ajit Menon? Dr. Panchalia, can you just come forward and... Dr. Ajit Menon? Oh, Dr. Digambar Nayak? Dr. Digambar Nayak is President Chairman of Goa Association of Physicians, Secretary of General Emergency Medicine, India. In the past, he led a number of medical organizations like IMA, Goa Medical Council, GMA, etc. Creator of Vrindavan Group of Hospitals, Vrindavan Nursing Home, Vrindavan Paramedical Institute, and many healthcare programs. Senior cardiometabolic and senior faculty to cardiology, emergency medicine, echocardiography, endocrinology, and physicians conference. Labeled as one of the 50 pathfinders of the Indian healthcare industry, along with stalwart like Dr. Pratap Reddy, Dr. Naresh Trehan, and Dr. Debi Shetty, Dr. T.M. Pai. An active researcher with a large number of highly credible contributions has created a number of medical videos, articles on national and international magazines, TV channel shows, and many more educational programs. Dr. Abhijit Tarabdar. Dr. Abhijit Tarabdar is a former professor and head department of nephrology, Institute of Postgraduate Medical Education and Research, IPGMER, Calcutta, ex-head department nephrology, Apollo Gleneagles Hospital, Kolkata. He is presently senior consultant nephrologist at the Department of Nephrology, Apollo Gleneagles Hospital, Kolkata. Dr. T. Govindan Unni. Dr. Unni is the first rank holder and best outgoing students of MBBS from Calcutta University, delivered Calicut Medical College Alumni Annual Oration 2004, recognized as inspiring cardiologist by Economic Times in Doctors Conclave 2018, regular faculty at annual national meets of Cardiological Society of India, Indian College of Cardiology, Hypertension Society of India, Indian Society of Hypertension, and Association of Physicians of India. Teaching faculty at several CMEs conducted across India, outside, recognized PhD guide of Kerala University of Health Sciences, 40 publications including 4 chapters in textbook, part of major studies like ACS Quick, Kerala Atrial Fibrillation Registry, Kerala Pulmonary Hypertension Registry, and Kerala Acute Heart Failure Registry. With this introduction, we are going to start the program, and the first speaker is, can I request Dr. Nakul Sinha to start with the proceedings?
So after this round of introductions, we get to the main program.
All right, so before we start the presentations, I'll request the speakers to please have a seat. Thank you.
Can I request Dr. Rajiv Gupta as the opening batsman in terms of the lectures to, for the next 15 minutes, hypertension-mediated morbidity and mortality, implications for India. And I personally believe there is nobody better qualified to give their thoughts more than Dr. Rajiv Gupta. Please.
Thank you very much for your kind words, sir. I'm going to talk of... I'm going to talk on a brief overview on the hypertension in India and what can be done at the population level as well as at the individual level. And I realize that there are lots of clinicians here, so we're going to talk on that issues. We all know that high systolic blood pressure is the most important cause of death and disability across the globe. Not well known is that also in India, it's the equally important cause. Till the year 2020, before COVID came in, before the pollution became a major event, high blood pressure was the most important cause of death in our country as well. Now pollution has taken over that role, but I think we need to remember that hypertension still is a very, very important cause, much more than the childhood diseases, much more than the neonatal diseases, much more than the maternal diseases and diarrheas and infections. We all know that cardiovascular disease is the most common outcome of hypertension. Cardiovascular disease, coronary artery disease, stroke, hemorrhagic, non-hemorrhagic, heart failure. All these three are the most important causes of death. And of course, we know other causes like kidney failure, peripheral arterial disease, and then potentiation of adverse effects of diabetes, obesity, and other cardiometabolic disorders. Almost 90%, at least in South Asia, deaths due to hypertension are because of cardiovascular disease. And this is similar to across the globe. all the deaths of hypertension are because of cardiovascular. We have been doing this study known as PURE, Prospective Urban-Rural Epidemiological Study, across the globe now, 30 countries, more than 200,000 participants across the globe. In India, we began in the year 2003, 2004. Kiran is here from St. John's, and I think St. John's was the first center in this whole study, and it began from St. John's, actually. So this is the data of 11-year follow-up of the Indian or the South Asian cohort, and we clearly see that hypertension is the most important cause of cardiovascular disease in our country as well. So clearly, no question that hypertension is important. What is not well realized is that the hypertension-associated deaths is the highest in our country. We compared high income, upper middle income, lower middle income, and low income. When we began the study, India was a low-income country, and clearly what you see here is the major cardiovascular events as well as cardiovascular deaths per 1,000 person-years of follow-up is the highest in South Asia, which is India, Pakistan, Bangladesh, 3 countries from South Asia. It's clearly a very important problem in our country, and we need to do it. We all know that lowering blood pressure is protective. Multiple studies, multiple meta-analysis, large meta-analysis, like the Oxford blood pressure lowering treatment trial is collaboration, clearly showing that almost 20 to 25% of reduction of the hypertension-related mortality by 10 millimeter systolic blood pressure reduction. So clearly, a very small reduction leads to a very major benefit. If you reduce blood pressure by a more amount, you get much more benefit. So how can we achieve low rates of cardiovascular outcomes, adverse cardiovascular outcomes in India like in other countries of the world? So there are challenges, and I'm going to share you some of them. The first challenge is increasing burden of hypertension, and there are geographic variations within our country of hypertension. It's a very surprising trial. These are data from the non-communicable research risk factor collaboration based in London. And they have compared hypertension prevalence across the globe over the last 20 years. And what they show is that South Asia is the only region in the world where the blood pressure is increasing. Everywhere else, the mean blood pressure levels are falling. So clearly, there is something wrong in our population, in our policies, in the way we manage hypertension. Many, many years ago, we showed that the hypertension was going up in our country. Unfortunately, this trend still continues, and the rural population is catching up now. There is an urban-rural convergence in hypertension, and these are about 10-year-old data, and if you see now, it's almost converged, and the urban-rural convergence is a very important factor in producing adverse cardiovascular outcomes of hypertension. We all know geography of hypertension. Variations are there. It's much more in the North India, in the South India, much less in the Central India. Unfortunately, there are data from the National Family Health Survey, large study, hundreds, lakhs of people diagnosed as hypertension. And what you see here is challenging. Hypertension is increasing much more in the central parts of the country. Rajasthan, Madhya Pradesh, Uttar Pradesh, Chhattisgarh. Traditionally, which were low hypertension areas, they're increasing much more rapidly among the young people. So clearly, in the next couple of decades, we are going to see much more problem of hypertension in the poor people, in the rural people, in the low socioeconomic status people. Clearly, we have a huge amount of challenge in front of us. The second challenge which we have is low status of hypertension awareness and treatment. And Dr. Robin Chatterjee just talked about that. There's a challenge in front of us. And again, you see the NCD risk database. You see that the red column in South Asia is increasing. It is falling in high-income countries. It's falling in Central and Eastern Europe, falling in high-income Asia-Pacific, increasing in South Asia, and slightly stabilizing in Southeast Asia and Latin American countries. So clearly, we have a problem there. We have national studies on hypertension, awareness, treatment, control. Young people, National Family Health Surveys, only about half of the people with high blood pressure are aware of hypertension, and the control rates are only 5 to 10%, clearly extremely small. And even among the older people, more than 45 years, as seen in the LASI study or the longitudinal aging study of India, the control rates, awareness rates are 60%, the control rates are 30%. So clearly, we have lots of work to do in terms of hypertension control. And our own studies in Jaipur have shown that although the control rates and the treatment rates are going up in the last 25 years, but we still have a lot of work to do. And finally, the last challenge is how do we achieve control and how do we reduce cardiovascular events in our patients with hypertension? And that's a clinical question. We all know that we have to have a good quality bureaucratic approach, political focus, health systems have to develop, financing has to improve, there has to be a technological support, we need to strengthen our health systems, low-cost medication, physician education, task sharing. But I think the most important pillar of the whole effort is the clinician like you who have to have a clinical approach for hypertension. We should not only start blood pressure treatment, but we need to ensure that the adherence is poor, is promoted, adherence is good. Task sharing, task shifting, patient empowerment are the new things which can help in adherence to hypertension treatment promotion. One important issue is this is the latest European Society of Hypertension guidelines, blood pressure classification. What they say is high normal 130, 140, and grade 1 is 140, grade 2 is 160, and so on. And I think these are very pragmatic sort of guidelines. And we have presidents of the European Society of Hypertension here, and I must congratulate them on producing a remarkable document. The task force, the whole task force produced a very remarkable document. And what they said was all the clinical trials are based on blood pressure of clinic-based blood pressure. And that's what is shown here, that clinic-based blood pressure is the way forward. Other question is how do we initiate treatment? I won't go into detail, but over the next 2 days or 3 days, we'll be hearing more about more about these factors. We'll be hearing more about the lifestyle interventions, which are important. You all know weight loss, diet, sodium, potassium, physical activity, tobacco, alcohol. All these have to be modified to achieve hypertension control. Lifestyle is the most important and the cornerstone of blood pressure management. Then we have various treatment algorithms. Many, many years ago, we adopted the UK NICE guidelines to Indian context, saying ABCD algorithm is useful. In between, the beta blockers disappeared from the scenario, and all the guidelines in the last 15 years or so excluded beta blockers. They say not effective and not good drugs. And they came to ACD guidelines. You start with low dose A plus C, or second step, high dose A plus C, and then you have triple drug and multiple drugs. But again, the ESH latest guidelines have come back on beta blockers, and they said that you always start dual combination ACE-ARB plus CCB or a diuretic, and they have said that beta blockers can be used as monotherapy or at any step of combination therapy. So clearly, we have gone back on beta blockers, looking at the evidence, and I think there have been and I'm sure there'll be great debates in the tomorrow session on beta blockers. Finally, we also reduce the risk in hypertension. So we need to think beyond the blood pressure numbers. We need to think on risk factors, like every moderate to high risk patient should be on multiple strategies, controlling our lipids, control of thrombotic factors, diabetes management, polypills are important, and multifactorial interventions are important to reduce cardiovascular events. And the final frontier, of course, is adherence. We just talk of that. Adherence is important. And how do we achieve adherence? I think as a clinician, that's my message to you. We need to think in terms of single pill combinations. Fortunately, in India, we have a huge variety of single pill, two drug, three drug, even four drug combinations available to us at a very low cost. We need to have screening and detection of non-adherence, which is very useful. And we could have a sensor-based technology. It is still a work in progress, but we ultimately go there, a sensor-based or simple wristband or wristwatch or ring finger-based blood pressure measurement technology. Hypertension in clinics is the way forward, and I was happy to learn that IPCA is trying to establish multi-center, multiple hypertension clinics across the country. Workplace-based interventions, team-based care, including GPs and pharmacists. We need to have technological support and patient empowerment, all using AI-based technologies. So finally, my dear friends, I have a food for thought. It's very important that we have a comprehensive overview of hypertension. It's very important that we focus on health equity issues, on engagement, not only with the patient, but also with the bureaucrats and the politicians, so that they ensure that hypertension is there on the map, on the chart. And I think things are changing in India. Hypertension has come up in a very big way in our country. We have to have accurate measurements available. It requires more research, especially in the use of sensor-based technologies and measurement of office versus home blood pressure, white coat, lifetime exposure, blood pressure lability, and comorbidities. All are important aspects of blood pressure management. For implementation, we have to have access to cuffs and other devices. We need to understand blood pressure outcomes, but we also need to understand health outcomes. Thank you very much for your attention. Thank you, sir.
Thank you, Dr. Gupta. And I think we'll have discussion at the end of this session, panel discussion. So let me invite Dr. Pancholia. He'll be speaking on a very conceptual thing, that what is the current status of the term prehypertension. In fact, that's very important, both in terms of prevention and treatment. Dr. Pancholia, please.
Thank you very much, Dr. Sinha. The term prehypertension, is it still valid in 2024? I'll start my presentation with the statement from Dr. C. Venkatram a few years back. Hypertension guidelines in the need of guidance itself. The multitude of the guidelines from the respected professional bodies and the individuals have caused, in my opinion, needless confusion bordering on the chaos. And see here, the US hypertension guideline mania, guidelines after guidelines and confusion after confusion. In 1939, Robinson and Brewster first proposed the concept of prehypertension, which was defined as the systolic blood pressure of 127/39 and diastolic of 80 to 89 millimeter of mercury. And when the JNC-7 came after that, in 2003, they endorsed the prehypertension stage here in the guideline. Later on, in 2013, the Korean Society of Hypertension divided it into two parts, the stage 1 and stage 2 prehypertension. Stage 1 is the 120, 129 and less than 80, and stage 2 is 130, 139 and or 80 to 89 millimeter of mercury. Then came to sprint trial in 2015, and they come out with that the intensive blood pressure control reduces the cardiovascular events by 25% and cardiovascular death by 27%. And that has again opened the debate on the optimal blood pressure target. Then came 2017 AHA-ACC guideline. They removed the terminology of prehypertension and put it as elevated blood pressure of 120, 129 and less than 80, that is a stage 1 prehypertension as elevated blood pressure. And stage 2 prehypertension, 130 to 139 and 80 to 89, is stage 1 hypertension. And they ultimately removed the term prehypertension and lowering the definition of hypertension from 140/90 to 130/80. What was the consequence of that reclassification? Nearly half of all the US adults, that is 45.6%, are now deemed to have hypertension, up from 31.9% according to JNC 7 criteria. Then came 2018 ESC guideline, and they put stage 1 hypertension, that is the 120 to 129 and or 80 to 84 diastolic, as a normal blood pressure, which was the prehypertension stage 1 by the Korean Society. While stage 2 prehypertension, that is 130 to 139 and or 80 to 85 to 89, put it as high normal. Now, why the change has occurred? The guideline authorities thought that the term prehypertension may have allowed clinicians to not to act on those blood pressure levels. And now that the term has been changed, it should be an indication that some intervention to be followed, like lifestyle modification or the drug therapy, should be started when the blood pressure is elevated. Another argument against the term prehypertension is that there is more risk of hypertension and cardiovascular event with the stage 2 hypertension, that is 130 to 139 and 80 to 89, while it is less risk with the hypertension cardiovascular event, less risk when the stage 1 hypertension, that is 120 to 129 and less than 80 millimeter of mercury. The risk of coronary artery disease was found to be 2.4-fold higher in the stage 2 prehypertension as compared to the stage 1 hypertension group. But we'll look at the meta-analysis. That statement was not true. Now look at the meta-analysis that is comprising of 4.68 lakh participants from 18 cohort studies, which clearly showed that prehypertension stage, that is 120 to 129, which is considered to be low-range hypertension, also having the increased hazard ratio of 1.3 to 1.6. And thus changing the level of 120 to 129, this is a challenge to the ESC guideline, that the level which was considered to be normal or put as a normal in the guideline, that is 120 to 129 and less than 80, which was the prehypertension stage 1, is considered to be normal by ESC, but that meta-analysis showed that even the low level of that particular level also having more hazard ratio. So what is there in the name? What the Shakespeare says, it is all the same, whether it is prehypertension stage 2 as per the JNC 7, or it may be hypertension stage 1 as per the ACC 17, or it may be high normal as defined by the ESC guideline 2018. Levels are remain same. What I feel that the division of the prehypertension is stage 1 or stage 2 by the Korean Society of Hypertension may be justified. At stage 1, that is 120 to 129 and less than 80, you have to go for the lifestyle modification, while at the stage 2, you have to go for the intensive lifestyle modification, and if necessary, when there is target organ damage, to go for the pharmacotherapy. When you come to the prevalence, it is around 25 to 50% of the adults worldwide. When you come to the Indian scenario, this is a study in 2023 published. Prevalence of hypertension in India, it is around 43%, while in Bangladesh it is 35%, and in Nepal it is 25%. And this is the latest data from the International Journal of Public Health, that is the National Family Health Survey 5, which clearly showed in India it is around 33.7%. Prevalence increases in the people with diabetes, people with microalbuminuria, people with chronic kidney disease, and those who are having high alcohol consumption. And these are the various risk factors for the prehypertension. What about the clinical significance? The level of 130 to 139 and 80 to 89, whether it is prehypertension stage 2, whether it is hypertension stage 1, or whether it is high normal, levels are remain the same. And the clinical significance, there is increased risk of progression into hypertension, increased risk of cardiovascular events, increased risk of stroke, increased risk of chronic kidney disease, and increased risk of pregnancy-related hypertensive disorders. What are the clinical evidences? Progression to hypertension. Patients with prehypertension are at twice the risk of development of hypertension compared to that with normal values. According to the Framingham Heart study, 37% of the high normal are progressed to hypertension in 4 years. What about the increased risk of cardiovascular disease? This is from the Framingham Heart Study. There is increased risk of myocardial infarction by 3.5-fold and increased risk of coronary artery disease by 1.7-fold. Increased risk of heart disease death associated with prehypertension and hypertension by the decade of the life, and increased incidence of cardiovascular event both in men and the women with a high normal blood pressure. There is poor survival when there is prehypertension compared to normotension, and this is from the Strong Heart Study. When prehypertension is associated with diabetes, the risk of events is more as compared to diabetes alone, and prehypertension during the early stage may lead to increased coronary calcium in the later in life. This is based on the cardiac study. There is increased risk of carotid intima media thickness, increased risk of left ventricular mass index, impaired diastolic function, and prehypertension is also very well linked with the cardiometabolic syndrome. And when it is associated with other risk factors, it increases the cardiovascular morbidity and mortality. What about increased risk of cardiovascular, cerebrovascular accident? And this is the data by C. Venkatram, published in the Indian Heart Journal long back. Stage 1 hypertension when shifted to stage 2 prehypertension, which is now called as a stage 1 hypertension by the ACC, the risk of or hazard ratio is increased so far as CVA is concerned. Increased risk of chronic kidney disease also, and the meta-analysis clearly showed even the lower level, that is stage 1 prehypertension and stage 2 prehypertension also leads to more hazard ratio so far as chronic kidney disease events are concerned. What is the basic pathophysiology behind that? Prehypertension subjects had a greater degree of renal arteriosclerosis and mesangial proliferation. And the prehypertension leads to CKD events in around 13.9% of the patients. And when you come to the end stage renal disease, not only prehypertension is stage 1, that is 120 to 129, and less than 80 also leads to more events related to ESRD. So prehypertension, is it relevant to nephrologists? Answer is yes. Considering prehypertension as a chronic kidney disease risk factor and its potential contribution to progression of chronic kidney disease, assessment of BP in the prehypertensive stage is important to optimize the early management and impact the attenuation of chronic kidney disease progression. So for nephrologists, prehypertension may be considered as a pre-CKD. Increased risk of pregnancy-related hypertensive disorders also seen with prehypertension. It predicts the pregnancy-induced hypertension and its postpartum progression. Prehypertension prior to or during the early pregnancy is associated with increased risk of hypertensive disorders in pregnancy and gestational diabetes. Prehypertension range after 32 weeks of gestation is a risk factor for decreased fetal growth also. What about the pathophysiology behind the prehypertension? RAS activation, oxidative stress, inflammation, a sympathetic nervous system activation, and central mechanism. What about the viewpoints from the Indian experts about the level of 130, 139, and 80 to 89? And this is from Dr. H.K. Chopra and Venkatram sitting in front of me. Circulation research viewpoint, what they pointed out, there is enough evidence to prove that BP levels between 130 to 139 or 80 to 89, that is the prehypertension stage 2, in the Indian population cause substantial cardiovascular disease, stroke, and premature mortality. And therefore, we should advocate the goal of BP level less than 130 by 80 for the most of the patients with hypertension. And lastly, couple of slides. Researchers are still using the terminology prehypertension, and I will show you some recent papers which are published from different countries. And this is the paper from Malaysia, 2020. They use the term prehypertension. This is the paper from China, 2021, using the term prehypertension. And this is a study from India, Rajasthan, 2022, using the term prehypertension. And this is again 2023 from China, using the term prehypertension. And this is from Iran, again 2023. These are the latest data, latest research papers. Vietnam also, and this is latest from BMJ Open 2024, this year only, few months back, using the term prehypertension. And this is from our own country, 1 in 3 suffering from prehypertension. They are still using the term prehypertension. In India, this is ICMR study, March 26, 2024. So the term prehypertension is still valid in 2024, though the terminologies have changed, but the BP levels remain the same, the target levels, 130 to 139 or 80 to 89. So बात वही है, नजरिया बदल गया ट्रीटमेंट का. You have to educate the doctors as well as educate the patient. Thank you very much.
Thank you, Dr. Pancholi, for a nice illustration of prehypertension. The next talk is by Professor Mencia. You will directly listen from the European Society of Cardiology. He is the president of European Society of Hypertension and chairman, Educational Board, European Society of Hypertension. So all his comments are very important for us to benefits of achieving the blood pressure goals. Thank you.
Thank you very much, and thank you for the invitation to this important meeting. Well, let me start with a concept which has been adopted since many years by the guidelines of the European Society of Hypertension. That is that the benefit of antihypertensive treatment is largely, if not exclusively, due to reduction of blood pressure per se, regardless how it is obtained. And this is documented by the fact that regardless the treatment, there is a linear relationship between the treatment-induced reduction in blood pressure and the magnitude of the benefit on outcomes. And the second evidence is that for a similar blood pressure reduction, there is a small difference or even no difference between different antihypertensive drugs. So if we accept this principle, the important question is how low we should go with blood pressure during antihypertensive treatment. What should be the target blood pressure? Now, in the early times, trials were based on people with very severe hypertension, and the problem of target blood pressure was not even raised. The idea was to lower blood pressure, maybe below 160 millimeter of mercury systolic, and see whether this was beneficial. Then other trials came in which the purpose was to reduce blood pressure not below 160, but below 150 millimeter of mercury. One of them was the HIVET study in very old people. And you can see that during treatment, blood pressure was reduced below 150 millimeter mercury, 144 millimeter mercury, compared to the placebo group, in which it remains around 160 millimeter mercury. And you can see that reducing blood pressure below 150 was associated indeed with cardiovascular benefit. Then several trials explored whether going below 140 millimeter mercury systolic and 90 millimeter mercury diastolic was beneficial. And you can see that this was indeed the case. This is a post-hoc analysis of the value study in which, the INVEST study, in which what we did was to see what was the effect on cardiovascular events according to the frequency, the rate, the number of visits in which blood pressure was reduced below 140 over 90 millimeter of mercury. And you can see that the more frequent was reduction below 140 over 90 millimeter of mercury, the lesser was the number of outcomes. And this was the case also for the risk of outcomes by adjusted analysis. And more recently, about 10 years ago, 2 large meta-analyses of randomized trials were published, and these meta-analyses, a comparison was done between patients remaining during treatment between 130, 139 millimeter of mercury, or 80, 89 millimeter of mercury, compared to those going below 130 over 80 millimeter of mercury. And it was clear that as far as hypertension-related cardiovascular events was concerned, there was a further benefit in those in which blood pressure was reduced below 130 millimeter mercury, 2 meta-analysis, or 80 millimeter mercury diastolic, and this was 1 meta-analysis of randomized trials. And I think today most guidelines recommend to try to lower blood pressure below 130 over 80 millimeter mercury in most patients from the general hypertensive population. Not all patients, but most patients from the hypertensive population. And this is what you can see from this slide, from the recent guidelines of the European Society of Hypertension, trying to go below 140, but also in many patients below 130 millimeter of mercury, and to go below 80 millimeter of mercury diastolic. Now the question is, shall we reduce blood pressure even further? That is, below 120/70 millimeter of mercury. Now, if we look at the epidemiology, this would appear to be the case. These are data from more than 1 million subjects, general hypertensive population. And you can see there is a linear relationship between blood pressure and cardiovascular events, stroke or coronary mortality at all ages. And the linearity starts from blood pressure values well below 120 millimeter mercury, 115, even 110 millimeter mercury systolic. But this is the general population. Hypertensive patients have structural differences from non-hypertensive patients. Vessels have a narrower lumen. The thickness of the wall is greater. And many patients have an increased left ventricular mass. And this causes alteration in the mechanisms regulating local blood flow. This is a very old study from our group in Milan. And people had intra-arterial blood pressure monitoring, and on the hemodynamic table also measurement by thermodilution of the coronary blood flow. And please notice that in patients in which there was no left ventricular hypertrophy, the yellow line, one could reduce progressively blood pressure by nitroprussate infusion down to 70 millimeter mercury without any reduction in coronary blood flow. But in people with left ventricular hypertrophy, the moment blood pressure was reduced below 90 millimeter mercury, diastolic in this case, well, you can see there was a precipitous fall in coronary blood flow. So things are different in hypertension as compared to normotension and the general hypertensive population. Yet data are available that if we go below 120 millimeter mercury systolic or 70 millimeter mercury diastolic, there can be some benefit. And these are data very well known from the SPRINT study. The purpose of the investigation was to see what happened if blood pressure was reduced below 120 millimeter mercury systolic compared to remaining below 140 millimeter mercury but above 130 millimeter mercury. And those going below 120 millimeter mercury, but in fact the achieved value was slightly above 120, 121, 122 millimeter mercury. Well, in these patients there was a 25% reduction in cardiovascular mortality. And there have been recently a meta-analysis of randomized trials going even further than the conclusion of SPRINT, because what was found in this meta-analysis was that when blood pressure was reduced even below 120 millimeter mercury, starting from 120 millimeter mercury and going below, well, there was a protective effect. Now, some of us are critical about this meta-analysis. First of all, you can see from the area that the data were somewhat inconsistent. That is, there was a benefit in those lowering blood pressure below 120 millimeter mercury, but not in those lowering blood pressure in the prehypertension range, or even in grade 1 hypertension. And then there were several other problems. I mean, several trials were not included. Patients below 120 millimeter mercury was a small fraction of the trial population. And then they made a mixture between trials in which the aim was to lower blood pressure and trials in heart failure and myocardial infarction in which there was virtually no difference, maybe 1 millimeter mercury difference between the different groups, just to mention 2 points of criticism. And it's hard to see how this was representative of the general hypertensive population. These are data from this meta-analysis, and you can see that in primary prevention, well, patients having less than 120 millimeter mercury had a higher risk as compared to patients having more than 170 millimeter mercury systolic. Now, the problem is, what are the disadvantages of being so aggressive in lowering blood pressure? First of all, no question that the more aggressive is the blood pressure reduction, the greater is the number of side effects. You can see that going below 120 millimeter mercury can increase by 3-4 times the risk of severe impairment of renal function. And this is a nice meta-analysis of Tomopoulos and co-workers showing that the greater is the blood pressure reduction, the greater exponentially is the increase in serious side effects leading to treatment discontinuation. And then there is the problem of the so-called J-curve, which is denied by some people, but indeed it exists. I could show you many examples. For example, if you look at the first line in all slides, people in this registry on patients with coronary disease, those going below 120 millimeter mercury had an increased risk of cardiovascular event. The same in on-target patients. The same in patients from INVEST. Those going below 120 millimeter mercury, they had an increase in cardiovascular risk. Now, the problem here is to interpret these data. This increase, which is called the J-curve, or can be defined the J-curve, is it due to vital organ underperfusion because of an excessive blood pressure reduction, or is it due to the fact that these are patients at a higher risk from the very beginning, before starting treatment? Well, maybe the latter explanation has an element of truth. In the analysis of the on-target study, we showed that those going below 130 millimeter mercury and having an increase in the number of cardiovascular events, they had a worse cardiovascular risk profile from the beginning. But this is probably not the only explanation. Reduction in perfusion of vital organs may also be a possibility. Again, these are data from the INVEST study, and you can see what happens in patients without cardiac revascularization and in patients with revascularization. And please notice that in patients without revascularization, lowering blood pressure below 70 millimeter mercury diastolic was associated with the J-curve phenomenon, in fact, a U-curve phenomenon. But those having had revascularization, well, the J-curve phenomenon was much less evident. And finally, there is one other point, and this would be the last point supporting the conclusion that we should be careful in lowering blood pressure below 120/70 millimeter mercury. And this is a post-hoc analysis of the INVEST study. And you can see the reduction in the risk of hypertension-related cardiovascular events by progressive reduction in on-treatment blood pressure. I would like you to notice that most of the benefit came from reducing blood pressure below 140 millimeter mercury, maybe below 130 millimeter mercury. Then there was a further very small additional benefit, but this was indeed very small. And you have to balance this further benefit with the fact that patients meet with serious side effects. Let me come to the conclusion then. And this is that there is no question based on the evidence that we should pursue a target blood pressure below 130/80 in younger patients, below 64 years of age. But in older patients, we should do this only if treatment is well tolerated and there is no major increase in side effects, because in real life, this leads to treatment discontinuation. Treatment reinforcement to go below 120/70 millimeter mercury, in the opinion of the European guidelines, should not be done. And then let me remind you that what I described as a possible target is related to the general hypertensive population, but there are conditions in which we should be more conservative. And this, according to evidence, is octogenarians, patients with isolated systolic hypertension, perhaps some clinical condition, such as, for example, left ventricular hypertrophy, and so forth. Thank you very much for your kind attention.
Thank you, Dr. Mencia, for the masterly talk on achieving the blood pressure goals. There will be some questions we'll discuss in the end of the session. Let me introduce a new person, Dr. Divangur Naik. He will be talking on the management of hypertension in old and fragile, a difficult topic, and their clinical implications. Dr. Naik.
Good afternoon, friends, and welcome to Goa. Yes, thank you. And welcome to such a beautiful rainy season. I'm sure all of you are going to get wet into the rain and enjoy this, the most beautiful season of Goa. Yes, the topic for my talk is management of hypertension in old and the fragile. Well, hypertension prevalence increases as we increase our age. That's for sure. Hypertension and fragility or frailty are closely connected. Hypertension may lead to frailty and may produce frailty by itself and disability through cardiovascular complications. Let's go straight to the risks and threats in treating hypertension in the elderly. I'm sure all of you are pretty well expert into this. And this is exactly what I'm going to sum it up in the next 10-15 minutes. Okay. The risk and threats in treating hypertension in the elderly. In the elderly, we have polypathology, we have polytreatments, we have a reduced compliance. There are many special conditions, and the most important is frailty. A major concern when treating an older patient, an antihypertensive drug should be hypotension, particularly orthostatic hypotension and postprandial hypotension. Orthostatic hypotension affects prognosis of older people by increasing risk of syncope and falls, and in turn increases cardiovascular risk and all-cause mortality. When treating hypertension in elderly, antihypertensive therapy should be carefully titrated, taking into account the standing position which should be the part of a standard evaluation of older patients and in their frailty. In particular, dysautonomic diseases such as Parkinsonism, diabetes, frailty should be carefully considered in order to avoid orthostatic hypotension. Other concomitant conditions associated with potential adverse effects during antihypertensive treatment that should be considered are aortic stenosis. Now we've seen our lifespan is increasing. Aortic stenosis is getting more and more complex things now. Heart failure, atrial fibrillation, reduced renal function, endocrine diseases such as thyroid and associated polytherapy. Frailty should be screened for and assessed during using validated tools. These tools investigate the various domains of frailty and may focus mainly on physical frailty on accumulation deficit or may perform multi-dimensional assessments. There are various good tools for frailty today with us. Fried Index, Rockwood Index, MPI, EFT, and many more. In fact, we have a quick one. It's a 10-minute assessment, which we normally use in our practice. We can have various scales for frailty, right from very, very fit to terminally ill patients. Now, this slide, I just want you to understand a little bit the trajectory of frailty. We have seen many times people beyond 80s, the moment something happens into their life, they are admitted into the hospital and we find them rapidly worsening. So if you look at the start of frailty, okay, at that time the person is fine, and then something happens in between, and quickly we find them reaching towards a terminally ill stage. Okay. This is the place where we as physicians play the greatest role of traveling them, of guiding them slowly during this sickness to a level where they can start recovering from their frailty rather than worsening to the stage of terminally ill. Now let's go to the current pharmacological management in elderly recommendations and BP goals. Blood pressure goals in patients with hypertension according to clinical condition and age groups. Numerous trials have assessed BP lowering in older patients and predominant systolic hypertension. Many subjects in these trials are unable to tolerate systolic BP level less than 140, let alone less than 130 that we want them to have. Nevertheless, older people did not have a clear reduction in cardiovascular, did have a clear reduction in cardiovascular events even at BP levels between 140 and 150. So treat them individually, looking, and you have to target it to each of the patients. Normally, 18 to 65 target for us would be 130 or lower, but not lower than 120, as it just put up to us just now. 65 to 79 target should be less than 140 to 130, and more than 80 target again should be 140 and not less than 130. In whatever is the situation, whether they have diabetes, whether they have CKD, whether they have CAD, or whether they have many more conditions along with that. BP targets for for drug treatment, the goal is to lower office BP to 130 by 80 in most of the patients, 18 to 64. Between 65 to 79, again, the primary goal of the treatment is to lower BP by, say, 140 by 80. However, you can try to reduce it a little further. While in patients between 65 to 79, only systolic hypertension, the primary goal of the treatment is to lower systolic blood pressure in the 140 to 150 range. However, a reduction of office BP to 130 or to 139 range may be considered if well tolerated, albeit cautious while the diastolic BP is less than 70. Office BP should be lowered to systolic BP of 140 to 90 millimeters of mercury range, okay, in patients above more than 80. However, even in here, reduction of office systolic BP to 130 or 139 may be considered if it is tolerated well. But keep in mind a few additional recommendations, please. In frail patient, the treatment target for office should be individualized. That's the most important thing. Do not aim to target office BP below 120 or below 70 during the treatment. However, in patients with low office diastolic BP, below 70, systolic BP should be low, could be still lowered if the treatment is well tolerated by the patient. And if, I would go and say, reduction of treatment can be considered in patients aged 80 years or older with a systolic BP of, even can be brought to 120, or if the systolic BP is 120, or in the presence of severe orthostatic hypotension or severe frail level. Friends, recommendations and statements. In patients 18 to 79, 140 to 90. In patients more than 80, the recommended office systolic threshold for initiation of drug treatment is 160 millimeters of mercury. However, in patients more than 80 years, a lower systolic BP threshold in the range of 140 to 160 may be considered. The office systolic and diastolic threshold level for initiation of drug treatment in frail patients should be, again, I would say, individualized. In adults patients with a history of CVD or predominantly CAD, drug treatment should be initiated in the high normal BP range, say more than 130 or more than 80. There are various schematic representation of BP profile in older subjects. I'm definitely not going to go through it for short of time. Algorithm for management of hypertension in subjects above 80. If preserved function, you have one way of looking at it. If there is a big loss, especially in ADL, there's another way of looking at it, or you can go fall in between, okay? All right. Dual treatment is usually the way to start with. Is ACE inhibitors or ARB, not both the things together, along with CCB or diuretics should be the first step. Second step could be ACE inhibitor, ARB plus a CCB along with a diuretic. Most of the patients will get control. You can substitute a beta blocker in between. And if they don't get control, then here is the place where we really have a severe resistant or malignant hypertension. And here we have to really look at a more individualized and a more expert way of looking at the patient. BP lowering strategies in patients older than 80 years according to their functions. We have a big list here. We have a big, nice analysis, okay? We can just go through it. Evidence for benefit of antihypertensive treatment in older patient does exist. If they have a problem, we must treat them well, and the evidence exists. There are various goals given by various guidelines. Okay. Therapeutic strategies with regard to non-pharmacological interventions for lowering BP, although benefits have been shown in younger population, there is little evidence from controlled studies in hypertensive patients above the age 80 plus. I do not think I myself believe into this because I have patients beyond 80 who are very, very good and very, very receptive for non-pharmacological way of management. If you if you explain to them nicely and if you take them along with you, and I have a large number of such patients who are doing very, very fantastically well. Most international guidelines propose the same 5 antihypertensive drug classes as for younger subjects: thiazide diuretics, calcium channel blockers, angiotensin converting enzymes, the inhibitors, then ARBs, and the beta blockers. Up to this level, when it comes to something beyond it, then you will go for centrally acting drugs and you will go for drugs which are vasodilators. Antihypertensive drugs, their adverse side effects will be a little bit more in elderly people, so we have to be careful there. Okay, clinical evidence, yes, we have a lot of clinical evidence that even at 80, you must monitor and individually look at the patient and try and treat their blood pressure wherever is required and wherever they can. These are a few studies. This is what it shows. Another study which tells us one thing, that in elderly people, most of the physicians do not worry or do not treat them as strictly as they should have otherwise been treated, the way we treat younger patients. But this is not correct. They all need help at that time. We all need help at that time. Take-home messages for you. I'm just finishing in exactly 15 minutes. Hypertension is highly prevalent in older patients, my friends. There are specific risks and threats in treating hypertension in elderly. Polypathology, polypharmacy, polytreatments, reduced compliance, special condition, frailty. Blood pressure targets for elderly patients. Individualize your patient in all your, individualize your treatment in practically every patient. And common side effects will be a little bit more in elderly, and you have to be a little more careful about this. And adherence treatment do have a few specific issues, but if you are careful, which I'm sure most of us are, we can treat all our elderly patients and give them the best and make them increase their lifespan, make them increase the quality of their life to their best. Thank you, my friends. Thank you so much.
Thank you. Thank you so much, Dr. Digambar Naik, and especially for keeping to time. And the next speaker will be Dr. Abhijit Tarafder, who is going to speak on CKD, kidney is the heart of the matter. So we'll be hearing a nephrologist talking to us about the kidney aspects of hypertension.
The solution. While we were searching for the solution, we came across this paper. This is a new concept, myocardial interstitial fibrosis. It has been found that myocardial interstitial fibrosis is characterized by diffuse deposition of an excess of collagen fibers in myocardial interstitium. CKD-specific factors like FGF23, which is elevated in chronic kidney disease patients when the phosphorus level is elevated. In order to tackle that phosphorus, FGF23 rises. In this particular patient also, the same thing happened. So most likely this patient had an element of myocardial interstitial fibrosis. So what could be the solution? Once again, there is another paper which showed heparin, which is being given regularly in maintenance dialysis. This patient was receiving heparin 3 per week. That can also facilitate binding of FGF23 to FGF receptor 4 in the myocytes. That causes myocyte dysfunction, myocardial dysfunction. So most likely, combination of these two, high FGF23 and higher binding of FGF23 to the myocyte ultimately led to repeated heart failure. What we did, we switched over this patient to peritoneal dialysis, CAPD, with icodextrin as the agent. And it is actually shown in USARDS data that hemodialysis patients are 56% more likely to experience de novo heart failure at 3 years compared to those who are on peritoneal dialysis. And use of icodextrin, as we have already said, which enhances peritoneal ultrafiltration, is said to be superior in volume management and prevention of heart failure. In this patient, the same thing happened. The frequency of heart failure and repeated admissions started to decline over time. From 3 months onwards, he didn't require any hospitalization. At 6 months, he was off heart failure episodes, and he is on maintenance dialysis as of now without any repeated episodes of heart failure. So what exactly I wanted to emphasize? I wanted to emphasize the fact that guidelines, quote unquote, are something which is a fantasy to Indian population, 70% of Indian population. When I worked 25 years in government hospitals, where this 2 millimeter difference of blood pressure and the benefit accrued is something like a nightmare. It doesn't speak anything. Patients come with uncontrolled blood pressure. They can't procure the medicines. So while managing these patients, please try to find out first thing, their affordability, whether they can afford finerenone, whether they can afford erythropoietin. This patient, we stopped sodium bicarbonate because sodium bicarbonate has a marginal benefit, but instead it raises blood pressure. Instead, this patient stopped important thing, that is clonidine. Clonidine is a cheap drug. Please try to confine yourself while treating a patient who comes from the lowest of the low socioeconomic background. These guidelines may guide us theoretically. For practical situation, one should go ahead with an individual patient, his adherence, his affordability, and that gives you the clue in treating the patient, because the individual patient's problem is unique to himself. And exactly that is the message I try to convince. Thank you very much.
Thank you. Thank you, Dr. Taravder. And the last speaker for this session will be Dr. T. Govindan Unni, who will be speaking on blood pressure levels and cognitive functions. Dr. Govindan Unni.
My dear friends, my topic today is blood pressure levels and cognitive function. Dementia is defined as a gradual and irreversible decline in cognitive abilities. It usually affects, by definition, people who are 65 years or older. The 2020 Lancet Commission on Dementia says that 40% of dementia cases could be potentially averted or postponed by addressing the risk factors linked to it. So dementia is a disease which can be at least partially prevented, like coronary artery disease, by treating the risk factors that are linked to it. And hypertension is one of the most important risk factors, one of the important modifiable risk factors. In fact, all the other risk factors for coronary artery disease or atherosclerosis is true for dementia also. Midlife hypertension has been consistently linked to cognitive decline, cognitive impairment, and dementia. Whereas if you look at late life hypertension, the data is a little confusing. There are some studies which says that late life hypertension accelerates cognitive decline and dementia risk, while there are other studies which says that late life hypertension actually protects against cognitive decline and dementia risk. We will come to that later. So you can say, in general, that the impact of hypertension on cognition varies across age groups. The 2017 Lancet Commission on Dementia Prevention, Intervention, and Care enumerates 9 potentially modifiable risk factors for dementia. These are less education, hypertension, smoking, obesity, hearing impairment, depression, physical inactivity, diabetes, and low social contact. So you can see most of the cardiovascular risk factors come here, like hypertension, smoking, obesity, physical inactivity, diabetes mellitus, all of them comes here also. The 2020 report adds 3 more. The 3 are excessive alcohol consumption, traumatic brain injury, and air pollution, which we now know is a risk factor for cardiovascular disease also. In fact, if you control 12 of these modifiable, eminently modifiable risk factors, you can actually prevent 40% of all worldwide dementias. So we are coming to a stage where we now know that nearly half of all dementias can, if not be prevented, at least be delayed by treating the risk factors. This is the Framingham hard data, comparing the incidence of dementia from 1977-83 to later years. And you can see that in general, there is a reduction in the incidence of dementia. It is postulated that this reduction in the incidence of dementia is due to better treatment, better control of risk factors. Well, remember, even though the incidence is coming down, the prevalence is going up because naturally people are living longer. Even demented people are living longer. Now, if you look at the cognitive domains targeted by high blood pressure, they are basically three. One is memory, two is executive function, and three is speed of processing. Among these, hypertension actually affects the last two, executive functioning and speed of processing. Impaired and declining speed of processing and excessive functioning are most commonly encountered by hypertension, whereas memory is much less affected. There is lack of consistent finding for an impact of hypertension on memory. Whereas if you look at Alzheimer's disease, a neurodegenerative disease, memory dysfunction is the most characteristic finding. So you can actually distinguish between hypertension-induced dementia, vascular dementia versus Alzheimer's dementia, looking at whether memory is affected more than cognitive function and speed, processing speeds. The harmful effects of hypertension on cognitive effects have been long known since 1960s. In fact, this paper published in 60s, which looked at the psychomotor speed of air traffic controllers and pilots, found that there is reduced performance, reduced psychomotor speed in patients who are suffering from hypertension. So hypertension has been associated with these two, cognitive impairment. One is reduced abstract reasoning, and the two is slowing of mental processing speed. Less frequently, of course, memory deficits. So when you compare Alzheimer's disease and vascular dementia, all these years, we have considered them as distinct nosological entities. One is as Alzheimer's disease, other is vascular dementia. But now we know actually it is not true. There is increasing evidence that these two conditions actually coexist, and both of them can be treated or prevented to a large extent by treating risk factors. The neuropathological hallmark of Alzheimer's disease are amyloid plaques and neurofibrillary tangles. And if you look at the data, 40 to 50% of people with this amyloid plaques and neurofibrillary tangles have vascular disease in the form of microcerebrovascular and macrocerebrovascular lesions. And on top of that, if there are ischemic lesions, they markedly enhance the impact of the AD pathology on cognitive function. So AD affects memory, they usually have vascular disease, and they affect the cognitive functions also. Traditional CV risk factors, forget about vascular disease, even otherwise, traditional CV risk factors have a role in AD. And there are estimates that say that if you treat the traditional cardiovascular risk factors, including hypertension, you can prevent at least 30% of Alzheimer's disease. Well, vascular cognitive impairment is the first thing that happens. That is the entire range of cognitive defects caused by vascular factors. And as the disease progresses, we go to vascular dementia, where there is day-to-day functioning is affected negatively. And hypertension, probably excluding age. Age is, of course, the most important risk factor. Hypertension is the second important risk factor for cerebrovascular pathology. So if we look at hypertension and brain, we all know that stroke is the one which is most prevented by treating hypertension, not coronary artery disease. Relationship between stroke and hypertension is more linear than all the other things. So cerebral blood vessels are the main target of the deleterious effects of hypertension. And so when the hypertension affects the cerebral vessels, the result is structural and functional cerebrovascular alterations. And these alterations underlie the neuropathological abnormalities responsible for cognitive defects. These abnormalities include white matter damage, microinfarcts, microbleeds, silent brain infarcts, and brain atrophy. The other, hypertension, the most modifiable risk factor for cerebrovascular damage, and we know that stroke has been significantly reduced over the past several decades by treating hypertension. Surprisingly, however, this has not translated, or at least we have not been able to produce data that treatment of hypertension has similarly reduced the impairment in cognitive function. It is not there, unfortunately. Another important factor is the cumulative blood pressure. And that is the reason why probably if you treat childhood blood pressure or adolescent BP, you have more benefit in reducing cognitive dysfunction compared to treating late life hypertension, because the total duration to which the patient has been suffered hypertension is probably more important than the degree of blood pressure. Because long-term hypertension leads to arterial stiffness, and you know the high wide pulse pressure producing pulsatility, leading to blood flow reduction in specific organs like basal ganglia and hippocampus, which are supposed to be the reason for cognitive dysfunction. Yet another aspect of hypertension is the blood-brain barrier, which is damaged, and that leads to decreased clearance of beta amyloids. And beta amyloid, you know, is an important protein involved in the neurodegenerative damage in Alzheimer's disease. This creates extra neuronal depositions, permits the media and adventitia of small arteries and capillaries, and finally lead to cortical hemorrhages. So there are several ways by which hypertension leads to cognitive dysfunction. So that is how it goes from hypertension to microinfarct to macroinfarct to enlargement of perivascular spaces and finally cognitive decline. Well, what happens when you treat hypertension? Several trials, including SPRINT, have shown that when you treat aggressive blood pressure target, go to an aggressive blood pressure target, cardiovascular disease is reduced, including overall mortality. But the problem, as I said, is with respect to cognition. Health and Age ABC study showed 3,075, 70 to 79, very elderly people, and they found that over a 10-year follow-up period, lower systolic BP targets were superior from cognitive perspective, and higher BP were not associated with better cognitive outcomes. Again, another meta-analysis, 28,000 patients, found that during a median follow-up of 4.3 years, antihypertensives reduced the risk of dementia by 13%. And several other studies also show that soft criteria like cerebral white matter lesions, decrease in global cognitive performance are reduced by treating systolic blood pressure. But there are other studies also. The STEP study showed multiple randomized multi-center trial, 60 to 80 years, reduced BP to 110 to 130 versus 130 to 150, and there was no change in cognitive function test score. So that was the problem. Again, podcast study, stroke and normal cognition, intensive BP was feasible and safe, but did not alter cognition over 2 years. That is a confusion with late life hypertension treatment. Probably the largest and most important trial is the SPRINT-MIND trial, which is a sub-study of the SPRINT trial. However, the trial has to be stopped early because there was a reduction in all-cause mortality. So we cannot really say whether there was a reduction in dementia if the trial has lasted longer. In this study, it did not result in a significant reduction of probable dementia, maybe because of early termination, maybe because the numbers were not reached, the expected cases of dementia did not come, and so it was underpowered. But one good thing about this trial was that there was always a suspicion that when you reduce the BP to very low levels, there will be hypotension, cerebral hypoperfusion, etc. But this study showed that there is no such negative effect. Intensive BP control did not result in harm to cognition after a median intervention period of 3.34 years. So SPRINT-MIND did not show any benefit in cognition, but it showed that it is safe and feasible to bring down the blood pressure to 120, even in those in the 70s category. The SPRINT-MIND thus showed that among ambulatory adults with hypertension, systolic BP of less than 120 versus less than 140 did not result in a significant reduction in dementia, but the possibility of hypotension, cerebral hypoperfusion, such negative effects were not there. The trial demonstrates no such negative effects on the brain. Intensive BP control did not result in harm to cognition. The problem is that if you take a 70-year-old man with a BP of less than 120, it is quite probable that his blood pressure has been well controlled over a long time. Or, as I already said, his cumulative BP load was actually low. This cannot be translated to say that you treat a patient at the age of 70, bring the blood pressure to 120, and he will have no cognitive problems. So that one has to understand that treating somebody at the age of 70 years is different from somebody who has a BP of less than 120 till his age of 70. Most cognitive impairments are mixed. There is no pure Alzheimer's dementia. There is no pure vascular dementia. Multiple brain pathologies are present. Cerebrovascular disease is very common even in Alzheimer's. And the high pulse pressure is one of the factors now found to be very important, more important than probably mean arterial pressure and age in older adults. And another upcoming variable is the BP variability, which is also now supposed to be very critical. And increased BP variability has been associated with stroke, CVD, dementia, and cognitive impairments. So to conclude, incidence of cognitive impairment is decreasing across the world because of better risk factor control, which definitely includes hypertension control also. But because longevity is increased, the prevalence is increasing. So you have a large number of demented people coming up because people are living longer. Even demented people are living longer. Hypertension is definitely an important risk factor. So are other traditional risk factors, including obesity, diabetes, dyslipidemia. All cardiovascular risk factors are important. Midlife hypertension definitely leads to dementia and cognitive impairment, whereas late-life hypertension, we are not very sure what are the benefits of treating late-life hypertension. But all said and done, the final point is that the 12 modifiable risk factors account for 40% of worldwide dementias. So concentrate on modifiable risk factors, and that is probably the crux of the story. Thank you very much.
Thank you so much to all the speakers. I'm sure that your insights were really valuable to each one of us. I'll request Dr. Kiran Varghese to please present the viewpoint summation on the session 1.
Thank you. All these speakers have given such a fantastic overview about hypertension. There's very little to add. We've heard from Dr. Rajiv Gupta how common this is, and this is the most common risk factor, especially for coronary artery disease and stroke. The lifetime prevalence of hypertension is almost 90%. So that really makes it very relevant for everyone sitting here and for the vast majority of our population. Dr. Pancholia told us about pre-hypertension and the confusion that has occurred on account of that. I think part of the confusion is because of the way hypertension has been defined. We know that the risk of stroke doubles with every 20 millimeter rise in systolic and 10 millimeter rise in diastolic, starting from 115 by 75. So from 115 to 135 is 20 millimeters. The stroke risk is already double. So the question is, why aren't we defining hypertension as 115 by 75? Because that is the point at which the risk starts increasing. But all the guidelines and many books also have clearly said that the reason why we define hypertension as 140/90 is that is the point at which the risk of, if you lower the point at which, if you lower the risk, the BP below that, the risk of intervention exceeds that of inaction. That means you need to prove that there is a benefit in reducing the blood pressure, and that point seems to be 140. We know that the risk increases, but does it come down when you pharmacologically lower it to that level? No, that has not yet been defined. So yes, high blood pressure is starting from 115 or 120. Optimal is supposed to be less than 120. Beyond that, it is abnormal, but do we treat it? Probably not. The sprint trial added to the confusion, but there the blood pressure measurement was done in a very different way, and that we all know. One of the things that the guidelines also clearly say that blood pressure should be measured at every visit to a doctor or a medical facility, which is not being done. It's not every visit to a cardiologist or a physician, but every visit to a doctor. And I think this is now much more easier with the availability of electronic devices, and the patient can himself or herself do it. Dr. Mancia has clearly said that at similar BP levels of lowering, the protective effects of different drugs are similar. We talk extensively about how one drug is better than the other, but even the International Society of Hypertension guideline and towards the end did mention, at the end of the day, lowering blood pressure is the most important, and how you do it is secondary. There is an exponential increase in the side effects when you increase the blood pressure control and try to lower it below the usual guidelines, and that is why we need to be a little more cautious when we try and go for more aggressive BP lowering. Dr. Digambar Naik has told us about the old and the fragile and how one has to individualize therapy in them. They are much more prone to orthostatic hypertension, and most of us in our busy practices, we rarely check the standing blood pressure. This is something which all of us should do and encourage our patients all to do when they are measuring the blood pressure at home. We have seen how there is a benefit when you lower blood pressure, but when you lower below 140, it's questionable. So in other words, the incremental benefit is not great, and when you consider the elderly whose lifespan is anyway limited, it may not make a great difference and could, on the contrary, be counterproductive also. Our nephrologist, Dr. Taraf there, told us about the CKM syndrome and how uremic toxins are profibrotic, and heparin also. I was not aware of that. And the benefit of his patient switching from hemodialysis to peritoneal dialysis. That was an eye-opener, and maybe that's also something we should keep in mind. Dr. Govindan Unni told us about the cognitive function decline and how hypertension and other risk factors are responsible for about 40% of the dementia that we see, and how we should continue to have aggressive control of all these risk factors, including hypertension. So just because the elderly don't tolerate hypertension, we should not have relaxed targets, but only in those who don't. So it should not be a blanket term that, oh, this person is elderly, we will target less. And there is also this feeling among a lot of people that this blood pressure is normal for my age. That's a concept which was abandoned decades ago. Studies in hunter-gatherer tribes have clearly shown that there is no age-related rise in blood pressure. So that is a function of our westernized style of living, and we should aim for aggressive blood pressure control. Dr. Govindan Unni also said that at midlife, the blood pressure is the risk factor, so we should aim for more early and aggressive treatment of blood pressure rather than wait till the patient is very old and then try to aggressively control it. I think I have already said a lot of points. I'll just hand it over to Dr. Rabin for additional comments.
Thank you, Keith. Thank you, Dr. Varghese. That was really a good summary. I personally thought it was a very good session, excellent session. I learned a lot, and I'm sure you all learned a lot. And the speakers, they presented extremely well, very nice, within time, and very useful information. Just to make it a short summary, I think the hypertension-mediated morbidity, Rajiv Gupta's data collection, so we all are aware of his presentation. His data is very phenomenal data worldwide known. And just one slide I was just thinking about that in Eastern India, he has shown that there is little less hypertension, But I was just thinking it may not be completely true because I think the data collection may not be quite appropriate in that region, because I'm quite aware of school health children, which I did in my personal experience. I do a lot of school health camp myself. And another senior colleague of mine, he was posted in one of the district hospital, and he is no more now. And he actually wrote a paper, Dr. Samuel Das, and shown that in school children, there's a significant hypertension in that district, and so is the clinical experience of my school health camp observation. And coming to the next speaker, Dr. Aditya Panchali, yes, very nicely he showed that prehypertension does exist, it is important, and we must be aware of that. Dr. Mansia's point is so well taken that aggressive reduction of blood pressure below 120 sometimes may actually be harmful, and that has to be kept in mind, especially somebody who is beyond sort of 65 years of age, and if we are aggressive and ensure that blood pressure goes below 120 to protect him from heart, brain, and other organs, but eventually that could be harmful. That is a very sort of well-taken point from his talk. And Dr. Digambar's talk about frailty, that is really, I was very impressed with the presentation, the way he classified frailty and the various stages that is described about the frailty and its relation with hypertension. Dr. Abhijit Sarabdar's very elegant case presentation, 3 elegant case, a very everyday clinical practice sort of scenario, and he nicely described cardiovascular kidney metabolic syndrome. And I think the stages of CKM from 0 stage to stage 4, 5 stages are worth listening and worth understanding. I'm sure that this is very important for us to remember. And the heparin in maintenance hemodialysis, how it can cause interstitial myocardial fibrosis leading into recurrent heart failure is worth remembering. And finally, Dr. Uni's talk on dementia, on cognitive function is extremely useful, especially his 12 factors which are contributing towards dementia and cognitive disorder. And in that 12 factors, hypertension is another important point. I was just wondering whether obstructive sleep apnea can also be there in that list, because that is another important point which can actually contribute to hypertension, even cardiovascular disease, cerebrovascular disease, and of course, a cognitive disorder. That is very nice presentation. Thank you very much. We are closing this session, but I'm sure there are a lot of questions which are going through in your mind. Please write down your questions in a small piece of paper which will be circulated by your team. We'll hand over these papers to our director, Dr. Venkatram, and he will go through those questions. And after the next session, he will collate those questions and answers all those questions the way it comes through. I hereby declare that this first session is closed. May I invite Dr. Venkatram to, or shall I do that? And Dr. Nakul Sinha to start proceedings for the next session. Thank you.
As Dr. Robin has said, that we are not having any mics for questions. So again, a sincere request, please write down your questions and you can address the faculty from whom you want to ask that question, the one who has given the talk. And we'll take it up one by one at the end of the session, which is now starting. So in the next session, we have another 5 lectures which are extremely interesting, important, and possibly giving us lots of food for thought. We are first having a lecture from Dr. Muruganathan on mechanism of hypertension. Till now, we have been focusing on etiologies, secondary hypertension, any hidden etiology. Let us see whether any better understanding of mechanisms, can they lead to a better selection of the drug or the mode of treatment or better outcome assessment? We'll like to hear Dr. Muruganathan, who is a distinguished professor from the MGR University, Chennai, and he's the director-elect of the API Physicians Research Foundation. He's the international advisor for Royal College of Physicians, Glasgow, and has many other accomplishments to his credit, including being the Dean of the Indian College of Physicians and the past president of the Hypertension Society of India. So, Dr. Muruganathan, please.
Good evening. Now I'm going to talk on mechanisms of hypertension in a nutshell. Though it is a very important topic, it is not often discussed in our programs. The pathogenesis of hypertension is very complex and involves an interplay of genetic, environmental, and physiological factors. As you see, genes and environment interact, gene-to-gene interaction with the regulatory mechanism, the hypertension is caused. So effective management of hypertension, prevention of hypertension, require a comprehensive understanding of these mechanisms, and it should be a multifaceted approach that includes lifestyle, pharmacological interventions, and public health strategies. 75 years ago, Irving Page proposed his mosaic theory of hypertension, which states that several factors including genes, environment, hemodynamics, humoral, endocrine, neural, adaptive, and anatomical interact to raise blood pressure. Of course, in the past 2 decades, we are talking about inflammation and production of reactive oxygen species. This is the mosaic theory of hypertension. You can see vascular endothelial dysfunction interacting with genetics, sodium intake, sodium storage, sympathetic activation. Of course, one of the points is microbiome, and then renal mechanisms all interact. So this is the mosaic theory of hypertension. The physiological mechanisms involved are mainly 4: cardiac output, peripheral resistance, renin-angiotensin-aldosterone system, autonomic nervous system. Of course, some of the other factors like bradykinin, endothelin, endothelin-derived relaxing factor or nitric oxide, atrial natriuretic peptide, viabin. Ladies and gentlemen, you know blood pressure is cardiac output into peripheral resistance. This one slide will give you, in a nutshell, the mechanisms of hypertension. You see excess sodium intake, reduced nephron number, renal sodium retention, increases fluid volume. So what all the things that causes the increased cardiac output? One is preload and the contractility. These things can be caused by stress, sympathetic overactivity, and thereby the preload and the cardiac contractility increases cardiac output. On the other hand, renin-angiotensin excess causes functional constriction, genetic alterations, cell membrane alterations, obesity, hyperinsulinemia, endothelial-derived factors cause structural hypertrophy. These things causes increased peripheral resistance. So, in a nutshell, the blood pressure is due to increased cardiac output and increased peripheral resistance. Now I am going to talk to you about subsequent slide, how cardiac output and peripheral resistance is increased. This is another slide which simplified the previous slide. You can see the stress can cause high sympathetic activity, excess sodium intake, and genetic factors causes increased fluid volume, and it increases preload. Again, I told you contractility. And genetic and metabolic factors also cause vasoconstriction. So you can see more of genetic factors, gene and gene interaction, gene and environment causes hypertension. And this is one just simple slide. To reduce the preload, we use diuretics. To the sympathetic overactivity, we do beta blockers. For the vasoconstrictions, we use calcium blockers and alpha blockers. For vascular hypertrophy, we use ARB and ACE inhibitor. Now I told you the heart rate and contractility because of the sympathetic system causes cardiac output, more cardiac output. Again, kidney, renin-angiotensin, aldosterone, and atrial natriuretic peptide factor can cause more fluid volume and increase cardiac output. So the major players, heart, kidney, vessel, autonomic nervous system. Let me talk about autonomic nervous system because that really causes all problems through heart, kidney, and vessel. The stimulation of the autonomic nervous system are sympathetic, both arterial constriction, arterial dilatation, and ANS is also important in the mediation of short-term changes in blood pressure in response to stress and physical exercise. You can see from this picture, the stress, from the brain, there will be afferent as well as efferent nerves. From the carotid baroreceptors and aortic baroreceptors, the impulses is going to the brain. Whenever the blood pressure is more, they fire the afferent nerves, and then immediately the brain acts, and through the efferent nerve, vagal efferent, to the heart, as well as sympathetic efferents also there, it goes to renal, as well as the muscles and the nerves, and it causes the neurohumoral mechanism. So mainly the neurohormonal mechanisms causes these through the autonomic nervous system, controls the blood pressure. Now we talk about sympathetic activity. What the sympathetic activity does? It increases the heart rate and contractility, increases vascular tone at the precapillary level, increases sodium and water reabsorption, induces vascular remodeling, and thereby increases cardiac output, increases peripheral resistance. Of course, one of the speakers was saying increased left ventricular hypertrophy and oxygen consumption, chronic ischemia and AMI, and induces vascular remodeling, which also causes increased diastolic pressure. Now, having talked about autonomic nervous system and heart, now we go to the kidney. Of course, our nephrologist spoke about the role of kidney, the heart of the matter. Many hypertensive patients have low levels of renin and angiotensin II, especially in black people. That is why ACE inhibitor and all may not be very effective. And because of the less sodium delivery, less renal afferent perfusion pressure, the renin is secreted because of the vasodilatation. And then renin acts on the angiotensinogen, the angiotensin from liver, and then it becomes angiotensin 1. ACE converts angiotensin 1 to angiotensin 2, and there are two receptors, AT1 and AT2. AT1 causes smooth muscle contraction, systemic vasoconstriction, vascular resistance, and aldosterone release, sodium reabsorption, reduced renal medullary flow, which causes blood pressure. The AT2 will produce anti-proliferative effect, natriuresis, and vasodilatation, and decreases the BP. Apart from that, there are also non-circulating local renin-angiotensin, epicrine, and paracrine systems, which also control blood pressure. Now coming to the vessel wall, endothelial dysfunction. The nitric oxide is secreted by endothelial cells, which results in relaxation of blood vessels. It also produces local vasodilators such as prostacyclin, endothelin-derived hyperpolarizing factor. As you know, endothelin is an extremely potent vasoconstrictor and also stimulates vascular smooth muscle growth. Recently, FDA approved an endothelin inhibitor. Now, vascular remodeling, endothelial dysfunction also in the form of abnormal balance between vasoconstriction and vasodilatation, and as well as structural hypertrophy, resulting in total peripheral resistance. Peripheral vascular resistance is characteristically elevated in hypertension because of alteration in structure, mechanical properties, and function of small arteries. Remodeling of these vessels contribute high blood pressure and associated target organ damage. The endothelial dysfunction is a very important factor. Vascular endothelial cells play a key role in cardiovascular regulation by producing local vasoactive agents. Dysfunction of the endothelium has been implicated in human. You can see there are two aspects. One is called vasodilating systems, parasympathetic, kallikrein-kinin system, prostaglandins, endothelin-derived relaxing factors, atrial natriuretic factor. The vasoconstricting systems are sympathetic, calcium, local renin-angiotensin, circulating renin-angiotensin system, endothelin, viabin, and vasopressin. Of course, vascular growth factors, insulin-like growth factor, growth hormone, parathyroid hormone, and tissue oncogenesis all can cause vascular dysfunction. Now, microbiome. We talk about microbiome. In every system, the microbiome has got a very important role. And if you see the microbiome as an emerging modulator of BP, sodium as a direct dietary constituent may promote hypertension by modifying gut microbiota. Dysbiosis has been observed in the range of disorders, including hypertension. In hypertension, it is associated with inflammation, structural changes in the intestinal wall, enhanced gut permeability. Altered intestinal permeability may facilitate egress of mediators such as microbial products, hormones, and immune cells into the circulation, where they can impact peripheral and central BP control mechanisms. Increased dietary salt causes significant alterations in the composition of microbiota and has been associated with accumulation of pro-inflammatory Th17 cells. Then oxidative stress. The role of ROS in hypertension: enhance vasoconstriction, thereby alter vascular caliber and reactivity, important vascular stiffening and for remodeling of microarterioles, enhance renal sodium reabsorption and thus enhance volume and cardiac output. Activation of matrix metalloproteinase and thus promote tissue remodeling. Increase neuronal firing in critical brain centers and altering neural control. Then sodium intake and sodium storage. The novel concepts related to salt and sodium intake. High levels of dietary sodium intake is linked with risk for hypertension. The sodium sensitivity is a relatively common phenotype associated with increased risk of hypertension and CV events. Salt-sensitive hypertension entails a renal defect in salt excretion. Increase in BP with salt intake is caused by increased peripheral resistance that requires a communication between kidneys and peripheral vasculature. A defect in sodium excretion by the kidney is a primary basis for hypertension, with impaired elimination of sodium during high salt feeding, leading directly to expanded extracellular fluid volume, promoting increased BP. Enhanced vasoconstriction, endothelial dysfunction can initiate salt-sensitive hypertension. One more theory, the high salt diet, of course, all of us know osmolarity, increased hemodynamic effect because of the sympathetic nervous system activity, cardiac output, and peripheral vascular system. The immune system, through the salt, also get the immune system affected, modulation of T cell activity, T helper cells, MN macrophages, and regulatory T cells. There is an alteration, and then systemic inflammatory and autoimmunity, which leads to endothelial dysfunction, increased sympathetic nervous system, and impairment in pressure natriuresis causes hypertension. So this is one of the other ways how salt can produce hypertension. Now genetics, because now lot of theories have come, gene-to-gene interaction, multiple genes, and polymorphic gene problems. Now the genetic factors, if you see, hypertension is about twice as common in subjects who have one or two hypertensive parents. Genetic factors account for approximately 30% of the variation in blood pressure in various populations. Some specific genetic mutations can rarely cause hypertension. The inherited tendency to hypertension resides primarily in the kidney. Increased plasma levels of angiotensinogen have also been reported in hypertensive subjects and in children of hypertensive parents. Hypertension is very common in African countries and black population in Britain and United States. The rural and urban difference in Africa are clearly due to lifestyle and dietary factors. And we are talking about a lot of syndromes in the genetics. You know about Batter syndrome in the ascending loop of Henle. There, the sodium chloride metabolism is affected. And then in the ascending loop, you can see the Giltman syndrome, the distal convoluted tubule, and Liddle syndrome because of, again, re-SSVPH1. And then a lot of other mineralocorticoid activities where there's apparent mineralocorticoid excess. And also 17-hydroxylase deficiency, 11-beta-hydroxylase deficiency, and 21-hydroxylase deficiency. All these genetic factors also, like Bartter syndrome, Liddle syndrome, and Giltman syndrome, all because of the genetic mutation, mainly because of the mineralocorticoid receptor and mineralocorticoid activities. Now, the major neuronal endocrine systems involve the regulation of blood pressure. I told you kidney due to endothelial dysfunction, salt sensitivity, vascular injury, premature pressure diuresis causes decreased BP, sodium retention, vasoconstriction increases the BP, and of course, natriuretic peptide, maintenance of sodium balance in the heart, and of course, vessel, I have told you, the nitric oxide, endothelin, and sympathetic activity, we have already said, immune function, and this is the nutshell how the hypertension is caused by the various mechanisms which I explained. And this is the last slide where the vessel wall is affected by environmental, genetic, CNS, cardiac, renal, and gastrointestinal, obesity, micronutrients, and then insulin, aldosterone, age. So ladies and gentlemen, this is the complex mechanism, but still we have found out various methods how we can control the blood pressure only if we understand the mechanism of hypertension. Thank you for your patient hearing.
Thank you, Dr. Muruganathan, for a very masterly talk on etiology of and mechanism of hypertension. Now we are going to have a very elusive talk by Dr. Professor Guido Grassi. He is the president of European Society of Hypertension Scientific Council from Milan, Europe, Italy. He is a professor of internal medicine and clinical medical university of Milano. He is the director of the Clinical Medical Institute at St. Gerardo Hospital, Milan. And he is the director of the Postgraduate School of Internal Medicine and of the PhD course in Public Health, University of Milan. He is a vice president. He was vice president in 2004. He was then chairman 2006 of the Working Group of Hypertension and the Heart in the European Society of Cardiology. In 2007, he became member of the task force of the European Society of Hypertension for the 2007 guidelines on hypertension. And he is member of Scientific Council of European Society of Hypertension from 2013-16 till 23. So let us listen to the distinguished Professor Grassi on independent prognostic factor heart rate, which is a very important for Indian scenario where we have got a basic heart rate is slightly higher than the European counterparts. Dr. Grassi.
Well, thank you for the kind invitation to this meeting. And in the next 15 minutes, what I will do is to address the issue of heart rate as potential cardiovascular risk factors. I will show some pathophysiological data, the evidence, the possible limitation of this association, and the importance of elevated heart rate as a therapeutic target. This is an old slide taken from the Framingham study showing more than 40 years ago that increasing heart rate, this data in men but also in women, there are a close relationship, increase the all-cause mortality independently from other confounding factors. And this has been also shown for sudden death in the same study. And more recently, Professor Mancha and co-worker, including myself, have provided a review of the potential importance of baseline resting heart rate on outcomes. And this slide refers to general population showing different studies, and you can see here that all-cause cardiovascular disease, myocardial infarction, coronary artery disease, heart failure and cardiovascular mortality in different 4 major studies have shown a close relationship between increase in heart rate and increase in events. This has been also shown in patients with cardiovascular disease, diabetes mellitus, or heart failure. Same major finding, increasing heart rate, increase risk of cardiovascular and all-cause events. This is also true in hypertension. This, again, are data from the Framingham study, more than 70 years ago, showing that increasing heart rate may provide a link for the possible development in future years of hypertension. Therefore, an increase resting heart rate is something that may be associated with elevated blood pressure. Which may be the factors responsible for this association? The first one is increasing heart rate may cause increased cardiac work and oxygen consumption, arterial wall stress, increase in blood pressure, particularly systolic blood pressure, decrease arterial distensibility, kidney damage. There is a strong association with microalbuminuria, and facilitation to coronary plaque disruption. And the link between heart rate and atherosclerosis is associated with changes, as I mentioned earlier, in wall stiffness, in endothelial shear stress, and also, and I will show you later, in sympathetic activation. The previous speaker has already mentioned the importance of sympathetic overactivity, not only for development of blood pressure elevation, but also for target organ damage. In this schematic slide, you can see that alteration in sympathetic activity, increase in adrenergic drive, cause a number of alterations, pulse wave velocity, alteration in vascular structure, and this may cause per se facilitation of the endpoint, coronary thrombosis, decrease in coronary flow reserve, and occurrence of sudden death. The link between heart rate and sympathetic markers is quite clear. This refers to a study we did years ago, showing that in different populations, healthy controls, hypertensive, obese, and congestive heart failure, if you have an increase in heart rate, you concomitantly have an increase in plasma catecholamines levels and in sympathetic nerve traffic directly assessed in humans by the microneurographic technique. And particularly, the cutoff for increasing sympathetic activation, at least in hypertension, is above 80 beats per minute, because above this cutoff, we can find increase in sympathetic markers as compared to the group of subjects in which heart rate was lower than 80 beats per minute. Increase in heart rate causes a number of alterations also in metabolic profile, increase in cholesterol, glucose, insulin, triglyceride, decrease in HDL cholesterol, and increase possible association not only with blood pressure, but also with body mass index. Therefore, overweight and obese subjects usually have elevation in heart rate. And the link between metabolic alteration and heart rate is probably associated or mediated by insulin, because there are a number of alterations in beta receptor and alpha receptor dynamics, which favors vasoconstriction, decrease in muscle glucose utilization, and therefore of appearance of decrease in insulin sensitivity, which is common in metabolic disease, but also in hypertension. Well, the link between heart rate and cardiovascular disease and cardiovascular death has been shown in a number of studies. This refers to patients in which there was an association increasing by age with occurrence of acute myocardial infarction and sudden death according to the increased quintile of resting heart rate. Please note that in all these studies, the association was independent from other confounding factors. The only alteration which is not closely linked to increase in heart rate is cerebrovascular disease, in contrast to the close association with coronary disease. The reasons are multiple, but in general, the positive association between heart rate and myocardial ischemia depends on, as I mentioned before, on the fact that heart rate is a major determinant of oxygen consumption, and this may cause, associated with other alterations, to decrease in coronary reserve to the circulation. Data has been also shown that heart rate may favor the plaque disruption throughout a series of mechanisms which may be dependent in part initially from metabolic alterations, but depends also to the increase in heart rate which cause the hemodynamic trigger for plaque rupture. And in several studies, these are data from the SCASA study, there is a close link again between heart rate and cardiovascular mortality in chronic ischemic heart disease. The elevation in heart rate at rest may thus represent an independent predictor of mortality in coronary artery disease patients. And in hypertension, as I mentioned, the cutoff for determining the increase in heart rate, which is associated with an increased cardiovascular risk, has been shown to be about 80 beats per minute, associated again with an increase in sympathetic activation. I have no time to discuss other factors which are important. Heart rate has been shown to be associated with target organ damage in hypertension, decrease in arterial stiffness, I mentioned microalbuminuria, and also I mentioned the occurrence of left ventricular hypertrophy, which therefore is in part dependent on heart rate and in part from the hemodynamic overload. Finally, in the last part of my presentation, I will briefly address the issue of the effects of antihypertensive agents on heart rate. You can see here a list of different drugs. Some of them may increase heart rate. This is the cause for short-acting calcium channel blockers, vasodilators, or diuretics, unlike others, may cause an important reduction in heart rate. This was the case particularly of beta-blocking agents, but also of drugs which may have effects on the renin-angiotensin system. And in different studies, it has been shown that reduction in heart rate, at least in this case for myocardial infarction, may cause a decrease in mortality rate when the reduction was sustained, such in this case, with different beta-blocking agents. And the relation between changes in heart rate and reduction in mortality has been also shown in a number of studies in congestive heart failure patients. The reduction was also shown in post-MI patients because this has been associated with a 10 beats per minute reduction, which estimated to reduce the cardiac death by about 25-26%. Therefore, there are cardioprotective benefits of drug-induced heart rate reduction, and this depends to a number of factors, which may be anti-ischemic efficacy, reduction in endothelial dysfunction, reduction in atherogenesis, as I mentioned, inhibition of sympathetic activation. This will be my slide, my last slide, therefore stressing the concept of the potential importance of heart rate in cardiovascular protection, not only in hypertension, but in general in cardiovascular disease. Thank you for your attention.
Thank you, Dr. Grassi, for a very thought-provoking lecture. And I think we'll have lots of discussion at the end of it. So let me invite Dr. S.N. Narsingam, and he is very well known in the cardiology and physician circles. He is the Vice President of the World Hypertension League and currently the Chairman of the forthcoming World Hypertension Congress to be held in February 25 in Chennai. He is also the Vice Chairman of the Lipid Association of India and has not only garnered many awards and recognitions as a clinician, a researcher, but also is responsible for guiding the associations to publish their guidelines. Dr. Narsingam, please.
Good evening, everyone. Thank you very much, Chairperson, for the nice praising words that were showered on me. Let me try to talk to you about the common problem that we normally encounter in a clinical practice is the lifestyle changes and the cardiovascular health. In fact, many of us had been doing it in the past and continue to do it, but patients are not able to adhere to the lifestyle modifications, so you lose interest ultimately. So let us try to dwell on this subject for the next 15 minutes. Cardiovascular disease is the leading cause of death in the world. It claims more lives each year than other non-communicable diseases in the world globally. In fact, it was published in the year 2019 WHO. 32% of the global deaths occurring are due to cardiovascular disease. In addition, we also have a leading cause of premature coronary artery disease death. About 6.2 million people die between the ages of 30 and 70 years. Cardiovascular disease affects individuals across all regions, countries, and socio-economic groups. Ischemic heart disease and stroke are the most common types of CVD causing mortality. The low and middle income countries are particularly affected by the burden of cardiovascular disease-related deaths. All of us know about the modifiable cardiovascular risk factors starting from hypertension, diabetes, dyslipidemia, obesity. What I would like to tell you is that many people with hypertension also have diabetes. Diabetic people also suffer from hypertension. The common problem is the obesity. If you take the central role played by the obesity, it is something phenomenal, which is probably happening in every person with diabetes, with hypertension, as well as dyslipidemia. Smoking is yet another problem. We need to concentrate on the most modifiable risk factor, which is in our hands, is the diet. Physical inactivity, increased stress, and a high alcohol intake. If you have combination of risk factors, the impact is much more. For example, if somebody has diabetes, in addition hypertension, in addition dyslipidemia, the amount of cardiovascular risk is actually ranged between 400 to 700%. Please remember that important information. The Inter-Heart study, which had evaluated 9 commonly occurring reversible cardiovascular risk factors, had come out with an important data. People who consumed higher quantities of fruits and vegetables, they had shown a reduction of 30% cardiovascular risk reduction. People who were regularly active, physically active, and avoided smoking, 80% lower risk of cardiovascular disease, particularly myocardial infarction. But people in South Asians, when compared to the Western population, I think most of them were physically inactive, and the lower intake of fruit and vegetables were identified in this population. Alcohol consumption, ladies and gentlemen, no protective effect among South Asians. The interstroke study has evaluated 5 commonly occurring reversible cardiovascular risk factors. They are identified that they have an impact of nearly about 80% of the global stroke risk problems. The Indian Diabetes Prevention Program, in addition, I think I need to tell you about the Diabetes Prevention Program, which was done in United States. But Indian Diabetes Prevention Program, which was conducted in our country by Dr. Ramachandran and his group, had evaluated that the findings are excellent findings. The risk reduction is about 28.5% with the lifestyle modification alone, 26.4% with the metformin alone, 28.2% with the lifestyle modification with the metformin. What does it mean? It clearly emphasizes one important message, that the lifestyle in diabetes progression and prevention plays a very important key role, which one has to remember. So taking into consideration all these important facts, I would like to tell you about the lifestyle modification. They serve as a crucial preventive measures for cardiovascular diseases. The risk factors may be influenced through lifestyle modifications. Addressing the modifiable risk factors results in the reduction of risk developing cardiovascular diseases. It provides long-term benefits for cardiovascular health. These are very important, 6 important areas where the lifestyle changes probably will produce a good cardiovascular health. If you concentrate on heart-healthy diet, increasing the physical activity, adequate amount of sleep and maintaining the sleep hygiene, reduction of weight and maintaining the weight, very important, smoking cessation, and addressing the so-called stress or the psychosocial factors will definitely play a role in maintaining the cardiovascular health and preventing the cardiovascular disease to some extent. In fact, ladies and gentlemen, this year, 2024, the International Society of Hypertension came out with the guidelines that there is a recommendation by a position paper which was endorsed by World Hypertension League as well as European Society of Hypertension, which had concentrated on food and drink, body and mind, movement and body weight. Of course, others were also included. One has to do it throughout the lifespan to get the maximum benefit. The first one started very early in life. Encourage healthy habits in childhood. That's not the responsibility only by parents. Even the school teachers should play an important role and the government should step in. Increase awareness of healthy food types. Parents, schools, as well as governments are responsible. Healthy eating, consumption of vegetables, fresh fruits, fish, nuts, unsaturated fatty acids, low-fat dairy products, low consumption of red meat, reduce the salt intake, reduce the sugar intake, increase the potassium intake, increase the consumption of plant-based food and dietary fiber, improve the food labeling, and implement the food taxation. In fact, I would like to tell you there are some evidences to talk about that the diet plays an important role in cardiovascular risk reduction. One is the Indo-Mediterranean study, which had actually recruited people who indulged in more fruit consumption, more vegetable consumption, legumes, walnuts, and almonds. They have shown a good amount of reduction in the CHD events, particularly in Asian Indians. There is a good old study called Leon-Hart study, 70% reduction in the cardiac events with the Mediterranean type of diet. What is the Mediterranean type of diet? It refers to a diet pattern inspired by traditional eating habits of people living in Mediterranean regions, particularly in Greece, Italy, and Spain. Abundance of plant-based food, including fruits and vegetables, whole grains, legumes, nuts, and seeds. Olive oil is a primary source of fat in this diet. Moderate consumption of fish, poultry is encouraged with red meat, which is reduced in quantities. The one study that had given a lot of information is the PREDIMED study, which is the primary prevention cardiovascular disease with the Mediterranean diet supplemented with the extra virgin olive oil or nuts, had clearly shown there is about 30% reduction in the risk of cardiovascular events compared to the control group, which had received only the low-fat diet. In fact, ladies and gentlemen, the meta-analysis of various trials which had used the Mediterranean diet has shown reduced reduction in the cardiovascular disease, including coronary artery disease, stroke events, and overall mortality. They improve not only the control of hypertension, but it decreases the cholesterol levels. LDL comes down, HDL goes up, the blood pressure comes down, endothelial function improves, the inflammatory markers come down. In addition, there is also increased insulin sensitivity. This picture attracts my attention all the time. All the all those people who are seated here must realize that this is a good picture that can be probably displayed in your clinic, where the patient can understand about the DASH diet and how to stop the onset of hypertension as well as the reduction of blood pressure. Fruits, vegetables, whole grains, low-fat dairy products, lean proteins, limited sodium intake. People who are given DASH diet plus sodium reduction has shown much more reduction in the blood pressure compared to people who received only DASH diet. Please remember that important message. In addition to that, the DASH diet also has shown through various other studies that it can improve the lipid profile, it can reduce the cardiovascular disease, it can reduce the development of type 2 diabetes, reduce all-cause mortality, cancer mortality, and CVD mortality. What about the plant-based diet, vegetarian diets, vegan diets, associated with the lower risk of cardiovascular disease? It had produced lower BP levels, improved the lipid profile, reduced the body weight, lower risk of IHD compared to non-vegetarian diets. There is one study which is called EPIC Oxford study, where vegetarians have shown 13% lower risk of developing IHD compared to the meat eaters. Very important information, ladies and gentlemen, which got published recently in BMJ. What is ketogenic diet? Ketogenic diet encourages high-fat protein intake while restricting carbohydrate consumption to as low as 20 to 50 grams per day. The diet intended to induce the state of ketosis in the body, promoting fat loss. The impact of ketogenic diet on cardiovascular health remains unclear. Please remember that. It remains unclear and does not appear in any society's recommendation. Intermittent fasting, it has picked up a lot. Intermittent fasting is a practice of alternating periods of normal food intake with the periods of little to no caloric intake. A popular weekly regime of 5 days normal eating with the 2 days of restricted eating, about 400 to 500 calories per day, which may probably result in many, many things. It can reduce the LDL levels, decrease the systolic blood pressure, decrease the diastolic blood pressure, decrease the inflammatory markers, and improves the glycemic profile. Please remember the importance of intermittent fasting. Oils. Which oil to be used? Just look at it. There's a good data that got published only this year by ICMR. The Nutrition Department of Hyderabad had come out with this recommendation that what oils, what is the amount of saturated fat in all these oils. Look at the ghee, lot of saturated fat. We don't recommend it. Palm oil, lot of saturated fat. Coconut oil, lot of saturated fat. You don't recommend it. Whereas sesame oil, look at it. You can see that the MUFA is more. Groundnut oil, MUFA is more. Probably you should have a good combination of high-rich MUFA as well as PUFA to have a good oil composition. These are the things which need to be probably avoided. The ghee should be avoided, the coconut oil should be avoided, the palm oil should be avoided. All those information, you can gather it from the ICMR study from the Nutrition Department of Hyderabad. Ladies and gentlemen, please remember, no single oil is ideal. Combining the various oil is always recommended. Hence, balance of different fatty acids can be maintained. There are no large randomized controlled trials, particularly on ghee consumption. This is a beautiful picture which I had downloaded from the ICMR Nutrition Department of Hyderabad, which had come out with this data. Swap these and compensate it with the healthier foods. For example, somebody has got a high-calorie food, it should be compensated with the other one. The same way, I think you can download these pictures from the ICMR InDiet and then try to have a good control of selecting the food, what you should consume. Again, another important method. This is the food pyramid, again published by the ICMR Nutrition Department. Healthy drinking, stop taking alcohol, avoid binge drinking, moderate coffee consumption, pomegranate juice, and then the beetroot juice, cocoa consumption has shown reduction of blood pressure as per the International Society of Hypertension. Physical activity, most important. Increase aerobic exercise, muscle strengthening exercise, incidental exercise, decrease the prolonged periods of seated, and then the physical activity has reduced the blood pressure. Aerobic exercise, 5 to 7 millimeters of reduction of blood pressure. Dynamic and isometric exercise reduce the blood pressure by 4 to 5 millimeters. Between the 5 age and 17 years, you should start even at that stage. Aerobic exercise, muscle strengthening exercise have to be advised. This is a common scene which are being witnessed by you when your children are doing the same thing, when your grandchildren are doing the same thing. don't encourage that. And then the physical activity between 18 and 64 years, 30 minutes of walking per day comes to about 150 minutes, or you can increase it also. Above the age of 65, of course, even adults, this posture is being adopted by me also sometimes. After going from the clinic, you sit comfortably in the sofa and then try to relax and look at the TV. But I don't spend more than half an hour. But if you're going to watch it in a prolonged period, probably that will result in a lot of complications. Above the age of 65, even those people need to get into aerobic as well as vigorous activities. Reduce the amount of time spent by sitting is equal to almost smoking, increases the cardiovascular risk. In fact, there is a good study published by American Heart Association. People under the age of 60 years, they were all observed who had spent more than 8 hours or less than 8 hours in the leisure period had shown 4 times higher risk for stroke. Please remember that important message. The Journal of Preventive Medicine had published the data. Brisk walking increases the tendency for the people to reduce the cardiovascular risk in people with the diabetes as well as in hypertension. The obesity, which we know, increasing alarming proportions, 40% in our country, more in South when compared to East, more in women when compared to men, more in urban population when compared to the rural population. The overweight and obesity, you have to reduce the weight. If you reduce the weight by about 10 kilos, you will reduce the blood pressure by 20 millimeters. And then stop smoking. The time spent in outdoors and pollution is high, you should limit this time. Consider the ventilation systems and the filtration. Conclusions, ladies and gentlemen, lifestyle modification has a profound impact on cardiovascular health. Implementing the lifestyle modifications can significantly reduce the risk of cardiovascular disease and improve the overall cardiovascular well-being. Comprehensive to lifestyle modification is the need of the hour. Lifestyle modifications should be sustained over a long period of time to get the maximum benefit. Personalized approaches are the best. If you try to observe the lifestyle modification, if you try to emphasize to your patient, if you try to re-emphasize again and again as the patient walks into our clinic many times in future, if you are going to do it, I think we can save the heart, we can save the brain. Thank you very much, ladies and gentlemen, for patient listening. This slide, I will show it at the time when we talk about the World Hypertension League. I will not dwell and take more time here. Thank you very much.
Thank you. Thank you, Dr. Narasingan. And now we'll go to the next topic, which is hypertension in adolescents, which will be by Dr. P.B. Jayagopal. Dr. Jayagopal is, I'm sure, well known to all the audience. He is the chair-elect of the American College of Cardiology, and he is the president of the CSI Kerala chapter.
Can I get the pointer? No, the laser pointer. No, laser pointer. You have a laser pointer here? Laser pointer.
Good evening, everyone. Hypertension in the adolescents, which by definition, according to the WHO, which is between the age of 10 and 19 years, is indeed a very, very difficult topic to talk about. In fact, I must really congratulate for the scientific chair to have brought in this topic, because this is one area where, as clinicians, as pediatricians, or maybe as treating cardiologists, we probably try to miss out checking the blood pressure of children. It's important to realize that this particular condition, the high blood pressure in the adolescents, it really starts in a susceptible person. It starts at a very early age. And not only that, when you really follow these patients, when it really tracks down to adult childhood, right from adolescence into adulthood, and not only that, these are the children. In fact, you heard Dr. Unni speak about cognitive impairment. Over a period of time, the effect of high blood pressure starts going down into adulthood, and these are the children who would get all the deadly problems of target organ damage and cardiovascular disease. So I think it's important to understand this and to see how best you could address this particular issue. Now, when you look at the global statistics, it's close to about 9.2%. In fact, this is a meta-analysis from our country, which shows that it's fairly high. It's about 7.6%. And then this is indeed a very huge figure. And then if you don't really screen this group of people, at least by the school health program and other screening methods, we are really going to miss a large chunk of the population, adolescent population with high blood pressure. In fact, this is a study by one of our own group members, Dr. Giva Zakaria from Trichur. And not only that, when you follow these patients in the young, and in fact, this was actually a group of people less than the age of 40 years, you see the kind of awareness, the treatment and the control, very poor control, even in a group of young hypertension. So understand that it's difficult to diagnose in adolescents, and in fact, the treatment will even be far worse than the scenario that you're seeing just now. Now, the major problem that has been encountered when you look at all the Western countries, and it's particularly true in a country like India, in fact, the obesity is really catching up. 1/3 of our population, at least from Kerala, we can tell you that 33% of the adult population is obese. And when you look at this adolescent population, what is even striking is that those children who are obese or raised BMI, in fact, when you follow up this group, it's been very clear that these people might develop diabetes over a period of time. It's not just that alone. If you look at this adolescent high blood pressure group, you find that obesity is probably the most important factor that need to understand is a mechanism behind it. And we also know that there is a 12% increase in the risk of developing cardiovascular disease, not just hypertension alone, but cardiovascular disease for each unit increase in blood pressure, BMI, among the adolescents. So I think it is indeed a major problem which really needs all the attention that it deserves. Now, when you start looking at the definitions, in fact, you will be confused because there's something by the American Association of Pediatricians, and then one by the American Society, the Italian Society is another one. We have a lot of senior faculty from Italy here. So, in fact, when you look into it, there are different stages. You look at the updated definitions. What do you see? If you just see high blood pressure, anything more than a 95th percentile, which is matched for that age and the body weight. In fact, it's important to understand in adolescents, the body weight as well as the age is taken into consideration. If it's more than 95%, yes, it is high blood pressure. And the stage 1 will be more than 130/80 or plus 12 above the 95th percentile. Stage 2 is more than 95th percentile or more than 140/90. So there are various definitions available. And the diagnostic algorithm, which is probably recommended now, is that you check looking at the blood pressure. If it's less than the 90, it is normotension, you just follow them up. But if it's more than 90, you need to keep them under surveillance. At any point of time, it becomes more than the 95th percentile, then you're fairly certain that these group of adolescents have a tendency, and you need to really evaluate for the etiology and organ damage. There's a lot of difference in the prevalence based on what guidelines you follow, and that actually is in terms of the white coat hypertension, the masked hypertension, when you look at these various guidelines in perspective. Now, what you need to understand is that the blood pressure increases with age and size. It's impossible to give a single cutoff value. That's why you talk about this percentile. Above 13 years, it's more than 19 percentile. Between 1 and 15 years, anything more than 95% on 3 different occasions. And it's also important the methodology that you use, because now there's a tendency to use all the oscillometers. But then in a child, it's not enough that you do that. You need to have a manual physical examination, the manometer, mercury reading, and you need to confirm. And we all know that it's very difficult at times to be really accurate about it. And it's important that the ambulatory blood pressure monitoring is captured in these children, because that probably is the best method to diagnose blood pressure. And also, the size of the cuff is also a very important point that you need to address. More than 16 years, whatever the adult criteria holds good there. Anything more than 140/90 and is high blood pressure, and the office target is always to keep it less than 130/80. And in the presence of a hypertension-mediated organ damage or a chronic kidney disease, the target will probably be less than 125/75. And this is again, this is the 2018 article which really gives very, very clear-cut ideas about this. Now, important thing is, I need to emphasize about the ambulatory blood pressure monitoring. It has got a superior reproducibility, and it's even in adolescent blood pressure, it is known to be associated with target organ damage. Diagnosis of white coat and masked hypertension can be clearly brought about by this. Evaluation of BP, the response to blood pressure therapy could be assessed with the ambulatory blood pressure monitoring. And sometimes there is a group of children who would have a resistant hypertension which could be confirmed. And of course, this is a more practical way of dealing with the blood pressure measurement. And today, the European Society guidelines is very clear, and it's important to understand that the blood pressure screening should begin at the age of 3 years. I mean, as early as that, because these are things which, if you miss it over a period of time, over the long term, these children will have all the problems of morbidity and mortality. The more important thing is, in a child, we need to understand that primary hypertension is probably as the more commonest cause for high blood pressure, but then secondary hypertension has to be ruled out. Again, just like what you see in adult, the renal parenchymal may be a very important cause, but then once in a while, you get to see the thyroid disease and the endocrine abnormalities. But I think one thing which we should not be missing is a coarctation of aorta, which is an eminently treatable condition. Not only that, there are probably substance abuse and dietary causes which are also responsible. Sometimes the drugs or therapies that you might use, steroids and conditions where it is indicated, which may also be the cause for high blood pressure. So much so, the workup is very important. A meticulous history is important, looking into all the associated illnesses, the comorbid conditions, whatever clinical pictures you have to really elicit for the areas where you should be able to rule out a secondary hypertension. Obesity, I think, is a major factor which you really need to address. Assessment of target organ damage, just like what you do in an adult, look for endothelial dysfunction. It might be very subtle, maybe just intima medial thickness, or again, looking for white coat hypertension, and when you have a doubt, use the home or ambulatory blood pressure monitoring. And I think, apart from the simple tests that we would do, there have been studies where uric acid, both in the serum and the creatinine. In fact, one of the largest follow-up studies is the Hang Hong study, adolescent hypertension, which is a study over a period of 30 years, where they have really documented that high uric acid in the serum and creatinine are important parameters which you need to really look into. Well, of course, ruling out secondary hypertension, I did not go into that. It's just to emphasize the point that one should be really meticulous in all the clinical examinations, particularly with the context of the coarctation. And it's important that when you check the blood pressure in a child, the right hand should be used, because in a coarctation, sometimes you get a lesser blood pressure on the left-hand side. So the right hand is the one right arm is one which you should be using to record the blood pressure. And of course, once in a while, you can get an endocrine abnormality which should be ruled out. Well, there are many guiding criteria. I really do not want to dwell too much upon it. It's known to everyone here, but it's important to understand that some of these secondary forms should not be missed. And of course, the more important thing is to understand, if you have a very significantly elevated, markedly elevated blood pressure in a child, it's more often due to a secondary hypertension than an essential form. That also gives you a help. If you look at the diseases, the aortic syndrome of the coarctation is the one which you would commonly see in a child or in an adolescent group. Now, how do you manage? Well, if it's a normal blood pressure, just as I had mentioned earlier, keep looking at it once in 6 months. Pre-hypertension, recheck it once in 6 months. And if it's more than 95th percentile, these patients might need a treatment. Stage 1 should be evaluated or referred to specialist. Stage 2 should be evaluated or referred more rapidly. And sometimes when it's an emergency with symptoms, these are the patients who, the adolescents which should be actually going to emergency therapy immediately. Well, I think whatever is applicable, in fact, you heard a fantastic talk by Dr. Narasimhan on the lifestyle modification. I think it holds pretty much the same here, weight reduction. I don't think I have to go into the details. Regular physical activity, because the more important emphasis is to reduce obesity, and actually that is one of the major reasons for adolescent blood pressure. Again, a word, I think we may not have to really look at the history of substance abuse, which is very common these days. And again, emphasize the point about DASH diet. I think the important thing is, I think I should again re-emphasize the point that looking into the BMI and trying to maintain this below the 85th percentile is what is recommended to prevent overweight in a child. Because these are important things to prevent blood pressure. And if it's between 85th and 95th percentile, gradual weight loss to reduce the BMI again goes a long way. But if it's more than 95th percentile, weight loss must be at least 1 to 2 kg per month to achieve a BMI below the 85%. I think this is one of the major recommendations to manage adolescent high blood pressure. Diet, the DASH diet, which was elegantly shown earlier, I think it's very important, but it's often difficult to use this in a child. Other thing is that you need to really work up for a diabetes and dyslipidemia, which has to be targeted and controlled. Reduction of sodium intake, again, a word about sweet and soft drinks, which the children might be really would be longing to have. I think it should be reduced. And again, the regular physical exercise, it cannot be overemphasized. Now, when do you treat this? I think very important message is somebody who has a symptomatic hypertension. What do you mean by symptomatic hypertension in adolescent? It's either headache or cognitive dysfunction. You heard Dr. Unni talk about the cognitive function. I think if you find that there is some evidence of a cognitive dysfunction, or let's say with an adolescent high blood pressure, that is a priority. That needs treatment, therapy. Secondary hypertension, I think it's very important to identify the cause, treat that. If you find evidence of a target organ damage, in fact, some of these children, if you look at the echo, you find something there, or let's say even in terms of renal dysfunction, needs to be addressed. Along with that, if you find diabetes, persistent high blood pressure, these are all strong indications for treatment. And then, if they need a treatment, pharmacotherapy, the difference between a management in an adult and an adolescent is, in an adult today, we all know the way to go about is a combination therapy, small dose of both. But in a child, it's always a single drug to start with, and that too in a small dose. And if it doesn't work, within the desired 4 to 8 weeks, you can escalate it to the target full dose. And then if there are no side effects, I think if it's not still controlled, probably you can add another group of drug. And the accepted class of drugs are exactly the same: ACE inhibitors or angiotensin receptor blockers, beta blockers, calcium channel blockers, and diuretics. So you have the long list there, just like what you have in the adult population. This could be utilized. Well, but then the dosage of this should be as low as possible in a child. And the blood pressure targets, when you start treating them, in general, it's to achieve below the 90th percentile. Now, only in the context of a chronic kidney disease, you need to be much more aggressive. Like, you need to bring it down less than the 75th percentile without proteinuria, and below the 50th percentile in case of proteinuria. I think these are important things which we need to understand, because the target organ damage is what would decide the outcome of these children. So a word about prevention. I think I again have to emphasize the fact that if somebody has a family history of high blood pressure, low birth weight. In fact, funny enough, this is a paradox. It's associated with the high blood pressure. If they are overweight and obesity, I think this is to be really brought sedentary behavior, substances that increase the blood pressure, cigarette smoke, non-sustained form, all these things should be addressed for prevention of high blood pressure. So the question is, where are we now in 2024? You look at the adult blood pressure therapy, you would say that non-pharmacological, if it doesn't work, go to the pharmacological. And then, of course, you have the newer trials which have shown that device therapy works. But in a child, it's not perhaps the device therapy, like renal denervation and so on. It's basically you need to identify secondary hypertension, and if that is there, it needs to be treated to give you the desired outcomes. So I think I would like to end my talk here by saying that adolescents whose blood pressure is in the highest percentile are most likely to become young hypertensive adults. And then you know all the problems and complications. Hypertension is prevalent in adolescents, associated with key risk factors, and the major things are obesity, diabetes, and chronic kidney disease, and this has to be addressed. The importance of hypertension as a modifiable risk factor is highlighted because early intervention during adolescence may help you to prevent all the various complications, catastrophe of hypertension in adulthood and later in life. Thank you all for the kind attention.
Thank you, Dr. Jayagopal. That was a great talk. I'd omitted to mention that he's the former national president of the Indian College of Cardiology, and he has done a lot of great research, and he's currently the national coordinator and principal investigator of the Heart Failure Registry. There are many others. I won't go into them. We'll move on to the next talk, which would be the last talk for this session, and that will be by Dr. Vijay Negalur. And he will be speaking on blood pressure elevation in pregnancy, clinical significance, a very important topic. Dr. Vijay Negalur is a consultant physician and endocrinologist, director of Dr. Negalur's Diabetes Specialties Center, and fellow of the Indian College of Physicians, president of Negalur's Academy of Diabetes and Research, founder member, Association of Diabetes Educators of India, and has several publications, including in the Oxford textbook and RSSDI textbook. Over to you, Dr. Negalur.
Thank you very much, sir, for a kind introduction. To begin with this talk, the blood pressure elevation, pregnancy, clinical significance, The gestational hypertension is the most common disorder in the human pregnancy. You'll be surprised to know that this elevation of blood pressure in the pregnancy does not occur in primates, in lower animals. Very interesting. And the important reason to realize is that the problem with pregnancy hypertension is because of the faulty placement of placenta. And furthermore, the placenta in the human being has the increased tendency for invasion in the endometrium. And because of that, it requires a large amount of blood supply to the fetus because the fetus has to grow its brain. So the growth of the brain is quite high in human beings compared to the primates. It's almost 5-fold higher. And that's the reason why it requires more blood supply. And that's the reason why we see the hypertensive disorders much more in pregnancy in human beings. So this is the global disorders which account for 14% of the maternal deaths because of hypertension. And hypertension disorders in pregnancy affecting at least 1 in 7 delivery in the hospitals. A third of these patients die during hospitalization for delivery. The WHO says that the lethal trifecta, or the unholy trinity of hemorrhage, hypertensive disorder in pregnancy and infection, claim at least 1 woman every 7 minutes. And we see there's an 18% incidence of hypertensive disorders in pregnancy, which was estimated in year 2023. And the maternal risk includes the placental abruption, the stroke, pulmonary edema, and multiple organ failure. And also to the fetus, there's an intrauterine growth restriction, prematurity, and intrauterine death. This is the Indian data, which looked at 18 studies, 92,000 patients, which says that the incidence is about 11%. And preeclampsia and eclampsia were reported as the main type of hypertensive disorders amongst the pregnant women. The important aspect to realize the association between the pre-pregnancy risk factors and the hypertensive disorders of pregnancy. We have the overweight or obesity, diabetes mellitus, and hypertension are the metabolic causes which ultimately result into gestational hypertension, preeclampsia, small for gestational age, and a preterm delivery, which ultimately results into multiple delayed complications. It is surprising to know that more than 2 lakhs patients studied over a period of 40 years. What was shown was the incidence of heart failure for those who had the pregnancy hypertension is 4-fold. The risk of stroke is 2-fold, and risk of ischemic heart disease is again 2-fold. So that is the impact of the hypertension which the lady has during her pregnancy, which she has to face subsequently 30 to 40 years down the line. These are the various predictors for the hypertension disorders in pregnancy, and the most important one, the unmodifiable ones, the pregnancy with in vitro fertilization and the embryo transfer, twin pregnancy, and the lab manifestation like A1C on early pregnancy, low sodium intake or a high sodium intake. Both of them are known to cause hypertension disorders in pregnancy. The lab elevation like abnormal elevations of IgE levels, and the higher caffeine intake, the higher coffee intake, and so on and so forth, are various factors which culminate into development of hypertension disorders in pregnancy. To classify the hypertension disorder in pregnancy, any woman in pregnancy who has blood pressure more than 140/90, if she comes before 20 weeks of gestation, then if she does not have proteinuria, then it's a chronic hypertension. If she has a new onset proteinuria and rise in blood pressure in the first 20 weeks of pregnancy and the maternal organ dysfunction, then it is superimposed preeclampsia. If she comes to you after 20 weeks of gestation and she has hypertension with proteinuria and multiple organ dysfunction with doubling of AST, ALT, and pulmonary edema and uteroplacental perfusion defect, then this lady has the preeclampsia. And if this lady gets convulsions subsequently, then it becomes eclampsia. And if the patient has new onset hypertension, which comes for the first time after 20 weeks of gestation, it's called gestational hypertension. And this hypertension gets all right after 3 months after delivery. The other conditions like white coat hypertension, masked hypertension do exist in these patients, and it also emphasizes the value of home blood pressure monitoring and ambulatory blood pressure monitoring in these patients. The important definitions of preeclampsia now is that there is always a significant proteinuria. There's a multiple maternal organ dysfunction, which can include acute kidney injury. As I mentioned about neurological dysfunction with eclampsia and altered mental status and blindness. And we also have conditions like pre-existing hypertension with which the superimposed preeclampsia and antenatal unclassified hypertension, which if the patient, the blood pressure gets all right after 42 days postpartum, then that is the gestational hypertension. The important change in the diagnostic criteria for the preeclampsia is that we do not require now presence of proteinuria to make a diagnosis of preeclampsia. So therefore, the so-called hypertension, proteinuria, and edema has been superseded by hypertension with end organ disease. It could be renal, it could be hepatic, it could be hematologic, neurologic, or a placental disease. Proteinuria is not sine qua non to diagnose preeclampsia, and the International Society of Hypertension, Gestational Hypertension says every pregnant woman should be investigated for multiple organ involvement, even if presenting without proteinuria. That's very important because this will include many patients who are neglected otherwise because there's no proteinuria. See, pathophysiology of eclampsia is basically it's the abnormal placentation, and because of that there's a hypoperfusion which brings in ischemia, and that brings about release of placental factors, especially SFLT1 and endoglin, and because of that there is an increased peripheral resistance in the blood vessels of the mother, and that increases the vasospasm and vasoocclusion, and that brings about symptoms of eclampsia or preeclampsia in a pregnant mother. So this is how you understand the two-stage disease. The first stage disease that occurs predominantly in the placenta, and that's because of the incomplete invasion of the extravillous trophoblast, and that's why the lining of these trophoblasts does not take place because of the incompetent natural killer cells, and therefore what happens is you get hypoxia production in the placenta. And because of the hypoxia, what you see here, that there are substances produced which are anti-angiogenic, which is the soluble FLT1, and we have endoglin, and other factors which get into maternal circulation, and those bring about intense vasospasm and vasoocclusion, and that brings the manifestation of the preeclampsia. So there's two-stage disease, one stage which occurs in the placenta, and because of these factors released in circulation, we get the manifestation in the systemic circulation. This was talking about the cellular immune response, because this abnormal maternal immune response to the invading trophoblast by defective placentation, and that's because of the defective natural T cells which are responsible for manifestation of preeclampsia. We have now early onset and late onset preeclampsia, one which comes before 34 weeks, the other which comes 34 weeks later. They have a different phenotypes which have a different cause for the preeclampsia. In the early onset variety, it's a vascular lesion. In the late onset, it's an inflammatory lesion, and the prognosis of the early onset is bad compared to late onset preeclampsia. The management of these patients depends on the treatment of blood pressure to get the blood pressure in the range of 110 to 140 systolic and 80 to 85 diastolic. The drugs that are used are the oxypurinol, labetalol, hydralazine, nifedipine, methyl-dopa, prazosin, hydralazine. Ultrasound from 20 weeks of gestation and thereafter every 2 to 4 weeks is essential, and monitor blood pressure, urine protein regularly, and induced labor at term. You try to get them at least up to 36 weeks of gestation. The hypertension pregnancy management, as per the NICE guidelines, says these are the drugs you use. The labetalol is the first choice, nifedipine is second, alpha-methyl-dopa is the third choice. You monitor these patients very frequently, and those patients who are critically ill require hospitalization and management in the hospital. This is one study which looked at the CHIPS trial versus tight control versus non-tight control. And here they tried to look at diastolic blood pressure, which is a less tight control of 100 millimeter mercury, and one with a tight control of 85 millimeter mercury. And what it showed that initiating therapy of hypertension, the threshold of 140 by 90 millimeter mercury and below 140 by 90 millimeter mercury improves the maternal and neonatal outcomes. The CHAP trial was a larger trial, looked at more than 2,000 patients, and the goal of the treatment in the tight treatment was 140 by 90, below 140 by 90, and the less tight was more than 160 and 100. And the conclusion was that the pregnant patients who underwent a tighter control of blood pressure had better outcome and they did not have a small birth weight baby. So therefore, it's important to control the blood pressure adequately. In these severe preeclampsia patients, patient requires the drug therapy. Sometimes they require intravenous drug therapy. They also require prophylactic magnesium sulfate to prevent eclampsia. They require corticosteroid for the baby's development of the lungs. And the magnesium sulfate is the anticonvulsant of choice and recommended mainly by the international guidelines to treat and prevent eclampsia. The drugs we should be avoided in pregnancy are ACE inhibitors, ARBs, diuretics, beta blockers, and calcium channel blockers, other than nifedipine, for the reasons mentioned there. There are some studies which looked at the prevention by using the drug. Aspirin is one drug which can be used at 150 milligram in the first trimester of pregnancy till term, and the aspiration administration resulted significantly lower incidence of preterm preeclampsia, and this was data on 27,000 patients. Metformin is also known to be anti-angiogenic and improves the endothelial dysfunction, and was shown to be effective in preventing preeclampsia. Pravastatin is the statin therapy, which improves the placental and maternal vascular disease, and there are trials underway, and these trials are expected to be released by 2031, and proton pump inhibitors like lansoprazole, rabeprazole have been shown to improve the placental release of SL51 and endoglobin and in vitro, and have shown benefit as the concentration of pravastatin. They can reduce the placental and vascular inflammatory cytokine production, and they also improve the nitric oxide and therefore bring about vasodilatation. These are some of the late effects that you see. These are the nice data again, talking about risk of a cardiovascular disease, stroke, and hypertension subsequently. The risk of heart failure is also pretty high in patients who have the pregnancy hypertension, which can be as high as to 2.6-fold to 4.6-fold, depending on the episodes of preeclampsia and the birth of the babies. This is the future health complications in women with the HTP. There is a risk of developing the chronic hypertension, which is 3-fold higher, stroke is 2-fold higher, atrial arrhythmias, all-cause death, coronary artery disease, so on and so forth. Besides cardiovascular, you have neurological diseases, you have a recurrence of HTP in subsequent pregnancies, you have involvement of the kidney disease, chronic kidney disease, then you have a lot of metabolic disease also, like obesity, insulin resistance, so on and so forth. So therefore, the presence of a hypertension in the mother can bring in so many complications subsequently. So that is very important to get the details of the history, especially when you look at the patient who comes in later part of life, what actually happened during the pregnancy where there was history of hypertension is very important. So therefore, the key takeaway message is hypertensive disorders of pregnancy is the most intriguing yet unsolved problems in the obstetrics. HTP are associated with long-term increased risk of a cardiovascular disease, screening for and treatment of chronic hypertension, dyslipidemia, type 2 diabetes, and overweight obesity following a pregnancy may delay or even prevent a cardiovascular disease among women with a history of hypertensive disorders in pregnancy. Labetalol, hydralazine, and immediate release oral nifedipine are suitable treatment options for the hypertensive emergency that you see in these patients. With that, I conclude my talk. Thank you very much for the patient listening.
Thank you, Dr. Vijay, for the very nice talk and a lot of learning from hypertension with pregnancy, which is a very neglected subject many times. To summarize the talk, which I can say that all the speakers have very elegantly done their job, and they have really shown us the various mechanisms. Dr. Muruganathan has very clearly showed us the various aspects of mechanisms, and though it is sometimes difficult to see what is the cause in that particular individual. But what you have to find out whether which area is more important in that particular individual, maybe primary cause or a secondary cause, that you have to find out by clinical examination and going from the history of the patients and see how the patient responds. Similarly, Dr. Jagopal has very rightly demonstrated the young hypertensive. One should not miss the various clinical pointers towards that. The only thing is that in a young hypertension in early age, the diagnosis of blood pressure becomes a real problem, and because of the non-availability of the cuffs which are smaller, which are needed, and the patient's, doctor's empathy not to check all the patients in the adult age, young age, and then you can get neglected. And the patient may be missed at that particular time when the treatment is required in a young age. The other thing which, as Dr. Grassi has very shown us that heart rate itself is a very important parameter for the control of the blood pressure, heart failure, and cardiovascular disease. He has said that the heart rate is not that important for cardiovascular disease mortality, but maintaining a blood pressure and a good heart rate, that goes a long term as far as management. And in Indian scenario, our heart rate is slightly oversympathetic drive is there, and our heart rate is slightly higher than the European counterparts. To keep the heart rate in heart failure as well as in hypertension, it will go a long way in the management of mortality and morbidity benefits to these patients. Dr. Narasimhan, as usual, he has always been very nice in elucidating the talk, and he has very emphatically talked about lifestyle measures. And he has also said that these lifestyle measures are not only important for blood pressure, but these are important for overall cardiovascular health. And whatever you do in lifestyle, whether the mild hypertension, moderate hypertension, or grade 1 or 2, all over place, you have to continue with the lifestyle measures and then take the benefit of this along with the pharmaceutical therapy. I think these are the very summarizing the talk, and now there will be those who has, Dr. Sinha will tell those who are having some questions, they can send the questions to us.
Well, the lectures have finished, but I think the more interesting part starts. Professor Ram, please. And do I see Robin also here? Okay, we'll call him. Please, sir. Has anybody collected the cards? Please, sir. Please. So, yeah, sure.
Ladies and gentlemen, we concluded the clinical sessions, and we'll have time for some discussion, and I have the cards. If I can ask the speakers of the sessions, they're putting chairs to please come. It'll be easier. Both from Dr. Rajiv Gupta to Dr. Negular, all of them, please come and be seated so that we'll make it faster. And the panelists that were introduced at the beginning of the program, if I can ask Dr. Indurkar, Dr. Hazra, Dr. Salagre, Dr. Jaysheelan, and Dr. Gulati also to come. And I know it looks like a large group, but we'll accomplish the goal. Don't worry about it. As they're being seated, we have a couple of more minutes. I want to mention something a little bit about one of our clinical scholars. All of them are great. to be seated there, going through the sessions, writing notes and all these things. It's amazing. One of the things that I have noted was there was a town hall meeting or a community meeting for lay public in Lucknow in May, where people from the community were invited to a medical program, hypertension, heart failure, diabetes, that was organized by Dr. Nakul Sinha. It was a fantastic interaction between the medical profession and the community, because a lot of times we live in our own little web. We create a web for ourselves and we talk to each other. But I strongly recommend, if you have the opportunity in the future to have that kind of a community interaction, that is very important for prevention of cardiovascular disease and also for arresting the progression of cardiovascular disease. So Nakul, is that okay that I mentioned about it? Thank you, appreciate it. Now, what I will do, I have collated the questions. If a question, your question is not answered, it is because the same question has been asked by somebody else. So don't feel bad about it. So these things happen. Now, is Dr. Manchia here? No? Okay, then what you could do is I could ask Dr. Unni this question, Dr. Anj. In the older patient, what is the level of diastolic cutoff beyond which you do not want to go? The usual question of low diastolic while treating systolic hypertension. So this will be answered by Dr. Unni, and then I am going to have our panelists also comment on it if they differ from you.
So the question, I think, has been discussed off and on again. The role of J-curve in diastolic hypertension. All the more true in isolated systolic hypertension, where you have a BP of, say, 180/70, and you do not know what to do. Now, in general, it is said that diastolic hypotension or low blood pressure is possibly of significance in coronary artery disease which is not revascularized, because the perfusion of the myocardium is in diastole, and so naturally there will be problems when there is a low diastolic BP. There is no real cutoff beyond which, in other people without coronary artery disease or in revascularized coronary artery disease, there is actually no real cutoff. And fortunately, when you give a drug for a BP of 180/70, the drug will act more on the higher BP. So the 180 will become 160, but the 70 is not going to become 50. 70 may be 65 or something. So most of the time we will be able to manage without creating any problem. But always keep a watch on symptoms, especially in a patient with non-revascularized coronary arteries.
Okay, thank you. There are 2-3 questions on it, so we'll eliminate it. Now the panel, if you agree with him, no comment. If you disagree, please comment.
Yeah, it's a comment on the commonest drug or the drug of choice for elderly hypertensive, amlodipine, again has a similar effect on systolic blood pressure rather than diastolic blood pressure. So as sir rightly pointed out, that is the benefit, and that's the drug of choice where we have seen that the octogenerations also and all those elderly hypertensive benefit. And that is why that 70 is a good cutoff, and that gets achieved also with amlodipine.
Okay. Now I want, in between, don't worry, everybody will get a chance. You can raise hands or legs, doesn't matter. Dr. Nakul Sinha has been sitting there patiently for the last 4 hours, so he has a chance to ask.
Just a small comment and question from Dr. Unni. You told very nicely about the dementia and other Alzheimer's differentiation. Especially after all this AF and NOAC's business for the last 10 years, they have come up with the micro-stroke recognition, where they are developing a biomarker just as troponin for MI, for very small strokes which may not be detected by MRIs even. So they are trying to develop a biomarker. I forget the name, I'm sorry about that, but I have read about it that a few biomarkers are being tried. Because they say that because hypertension and old age are the greatest risk factors for AF. So there is a possibility that even if the patient is in sinus rhythm, you may have intermittent AF and those micro strokes may be causing dementia. And they are promoting or rather advocating that we may consider NOACs in some high risk cases where AF has not been demonstrated. I would like your comment on that.
Yeah, that is true. Even otherwise, I think there are at least some people who believe that the Charts-Loss score is actually applicable in patients even without AF. Because somebody whose Charts-Loss score is high, even without atrial fibrillation, he has a high risk of stroke. But as at present, we don't really have any evidence that you can apply the Charts-Loss score to people without atrial fibrillation. So right now, only in atrial fibrillation you use that. But as Dr. Nagul Sinha said, it is quite possible that as we get more data, we may use Charts-Loss score in people without atrial fibrillation also.
Thank you. What we'll do, we have a number of people, so the responses can be brief. But if they want more than abbreviated response, then they will meet it separately. Now, I have combined CKD questions. We have two nephrologists here. So both of them can answer whatever it is. So Tarabdar, in CKD patient, would you prefer as a first line either ACE or ARB, the usual question? And at what level of GFR would you stop or withdraw the RAS blockers? The usual question. Please comment on it, and then I want Dr. Gulati also to comment.
Okay. Firstly, when there is combined heart failure and CKD, usually we prefer ACI over ARB. Otherwise, ARB is good. Most of the studies are with ARB. Blood pressure control, plus minus. Some of the older ACIs, they are very good in controlling blood pressure. The newer ones may not be. But the important question that you have asked is the cutoff creatinine. Actually, there is no cutoff creatinine. The fact is, we usually allow the patients to continue with ACI ARB if there is deterioration in renal function, and more importantly, if there is hyperkalemia, sometimes we withdraw. But by and large, in most patients, we prefer to continue with ACI ARB. Sanjeev,
Sanjeev,
Dr.
you
Gulati,
want to comment?
So I would absolutely agree with Dr. Tarabdar that ACE or ARBs are really the first-line drugs for all CKD patients. In fact, if we had our way, we would have put them in all our mineral water bottles. I mean, they're that good. So the STOP ACE trial looked at whether it was beneficial to stop these ACE or ARBs at lower levels of GFR, and it was a negative trial. The cardiac benefits remain there irrespective of, the level of GFR. And that's why even in our dialysis patients, we prefer after beta blockers, the only place where beta blockers have unequivocal benefit, it has been shown, is in dialysis patients. And the second drug which has been shown to have mortality benefit is ACE or ARBs. And as Abhijit rightly said, more than the eGFR, you have to look at the potassium.
Okay, thank
Just
you very much.
One more point I would like to add. ACIs, they reduce thirst. That's the reason in dialysis patients, sometimes we restart ACI because in these patients, sometimes volume is a problem. So we discontinue ACI in between, then restart ACI when the patient is on regular dialysis.
Okay, thank
so
you.
One small question. Yeah. A patient of heart failure had decreased creatinine clearance. He is on spironolactone and ACE inhibitor. So what will you stop? both of them or any of them?
So in heart failure now, with sacubitril valsartan being there, I think that would be my drug of first choice, unequivocally. So I would get him off both of these and put him on sacubitril valsartan. And to this extent, as the index patient that Abhijit presented, we have had similar patients in dialysis who have had heart failure, and you put them on a very tiny dose of sacubitril valsartan and there's a dramatic benefit, I mean, again, the underlying cutoff is more of hyperkalemia than anything else. So I would get rid of aldactone, I would get rid of all this, just put him on sacubitril valsartan.
So what do you mean by tiny dose? How much?
Okay, yes. So some of, our cardiologists joke that we are homeopathic cardiologists because we start with 25 milligram, once daily, and valsartan, mind you, requires renal dose modification. So sacubitril valsartan, starting off with, we use a OD dose, start off with 25 and up titrate it to 50.
Thank you very much. Now,
just one quick question to
Rabin, Nakul and Rabin.
Yeah. Regarding the dose, Sanjeev,
yes, sir.
There has been a dose modification study of ARNI.
Right.
And they have shown that even if you can't go beyond 25 twice daily, you are getting more than 75% of the projected benefit. It's basically the maximally tolerated dose of ARNI which benefits you, whether it is 200 or whether it's 50 or something. So let's not bother. I mean, the main limitation will be blood pressure.
Absolutely. Sure.
Okay, Rabin.
Just one quick question to Sandeep again. Is one of the index case where Dr. Tarabdar has presented CKD and kind of heart failure. And in addition to 4 pillars that usually we prescribe, and he also suggested, currently there is also some role of vericiguat, especially with low GFR, vericiguat. What would you recommend as a nephrologist?
Yeah, it can be used. I mean, vericiguat is a drug that again is more in the realm of cardiology, and certainly these patients continue to be symptomatic. Although by and large, I've seen that they do remarkably respond to sacubitril valsartan, but anecdotal cases, we have used vericiguat again in coordination with our cardiology colleagues. Yeah.
Okay.
Sir, when ARNI cannot be used when EGFR is less than 30, this vericiguat has got definitely a role. Even it can be used up to EGFR of 15. So that's the advantage with this molecule.
Well, ARNI, I would again, disagree that it cannot be used. I think the word is used with caution, and again, the principle is the same, like with ARBs, just look for hyperkalemia. I mean, don't deny these patients. In fact, we don't have good potassium binding resins. My colleagues in US are so aggressive that they would, even in a patient who's got a potassium of 5.5, 5.8, they are using ARNI along with potassium binding resins because they say that the benefits outweigh the risks.
Thank you. You know what, Dr. Rabin Chakrabarti told me just now that anybody who repeats the same thing, he is going to deduct some marks. So I don't know how much he is going to deduct. Your marks will be deducted if you repeat the same thing. Dr.
This great enthusiasm for the kidney reminds me what I was told about a kidney textbook, that the first words were, the heart is an organ which sends 1/5 of its output to the kidney.
You hold on the microphone. No, there was a question for you. What is the lowest diastolic blood pressure in the elderly that you will tolerate or the patient will tolerate?
That's a very important question. The answer cannot be clear, unfortunately, because there are only few studies, post-hoc analysis of the data, no randomization, of course, and some of them suggest that the benefit, for example, of treating isolated systolic hypertension can decrease if diastolic blood pressure is below 70. Not all studies have found this. But of course, one would imagine that this is a good reason for caution, particularly in the elderly. That is that one should, and this is mentioned in the European guidelines, one should be careful in lowering systolic blood pressure too much if diastolic blood pressure is around 70 or below 70. So the target for isolated systolic hypertension is not less than 130, is less than 150, 1A. That is the highest evidence because of randomized trials. If people tolerate, then one can try to go below 140, but remaining above 130. And the value of diastolic blood pressure, of course, has to be taken into consideration. But this is based on consensus, it's not based on undisputable evidence.
Thank you.
I think one point I would like to highlight that diastolic blood pressure is extremely important because we all know that coronary filling happens during diastolic.
Sure.
And the diastolic filling depends upon the gradient of aortic diastolic pressure minus left ventricular end diastolic pressure. So if the aortic diastolic pressure is, let us say, 30, and LV EDP at, let us say, 20, so the gradient is 10 millimeter. So obviously the coronary filling may get compromised. So there is a cutoff point beyond which if the diastolic pressure falls, then the coronary filling will get compromised.
Thank you very much. When this card is given, Dr. Sitaram, you're supposed to write only one question. You wrote 5 questions in one card. That's almost like 5 cards. Boy, that's not fair. That's not fair. One question, one card policy should be implemented. But having said that,
add a comment, no, just a comment on this, because pathophysiological considerations are very important. Unfortunately, guidelines usually are dominated by epidemiologists. They don't give much to pathophysiology. And this is one of the reasons why you can hardly see pathophysiological concepts in guidelines.
thank you.
And this is bad, of course.
Sure, and they're still fine. What Dr. Manchia has suggested, just to break the monotony, in one JNC, I don't mention the JNC number, in one JNC, half the members of the writing committee have never taken a blood pressure on a human being, I know them, I know them. So anyway, let's come back to this multi-question card. Tarabdar and Gulati, these are, in your first case, I don't remember what your first case, I hope you remember, is any possibility of adding protein restriction to that patient? Your case number 1?
So yeah, I think protein restriction is a very important and I think one of the most mismanaged aspects of chronic kidney disease. There are very elegant studies to suggest that there is no role of protein restriction in a plant-based diet in chronic kidney disease. You know, because as such, the biological value of these plant-based proteins is less. Certainly, the Western diet, which is predominantly an animal protein-based diet, there is a role of restricting these proteins to about 0.7 grams per kg per day. And mind you, if we all go back today and just analyze our protein intake per day, most of us are not even touching the 1 gram which has been recommended by the ICMR. So we are all sitting at 0.8 and most of the patients in chronic kidney disease, thanks to all the babas around, all Baba Ramdev and all, by the time they come to us, they are malnourished. So for heaven's sake, I think we need to propagate that, that please do not restrict protein in chronic kidney disease in an Indian plant-based diet.
Firstly, as you have already said, sometimes I give a quiz to my students. You make up a chart and see how much protein do you consume. And there it is found that most of my students also, they consume a protein per day which is less than 0.7, maybe 0.6 gram. That is one. Second is, some of the protein constituents of our diet is rich in phosphorus. So what we do is we restrict phosphate. While restricting phosphate, sometimes we have to restrict animal proteins and some of the protein supplements which are rich in phosphorus. So it is not protein, but it is phosphorus restriction which is more important.
Okay, keep the microphone. Interventional cardiologists will not like it. At what level of GFR would you tell these interventional cardiologists not to do coronary angiogram?
Okay. Once again, there is no cutoff. At one point, there is a hypothetical cutoff of 2.3. Now it is said that no, it is not. Second is, there is initially an interesting observation that the rule of half. If a patient has got renal dysfunction and if you subject the patient to contrast, then half of the patient may develop. Now it is said it is less than that, maybe 30%. And those patients who develop renal dysfunction because of contrast-induced nephropathy, half of them will recover, half of will not recover. And half of them who do not recover will require dialysis. That was the rule of half at one point. We don't follow that rule nowadays. But now it is around 30% that the usual statistics that these patients may have contrast-induced nephropathy. But once again, the fact that I wanted to highlight was because of the fear of CIN, if you withhold contrast investigations, then ultimately you jeopardize the lifespan of the patient because there may be some life-threatening complications. So in such patients, please allow it. If CIN develops, treat it. If required, dialyze the patient. And if required, whatever CABG or intervention is required, please let the patient to have that.
So these days we go ahead even with primary angioplasty in a dialysis patient and just get them dialyzed.
I want to tell the physicians what nephrologists say. They don't care about anything because they can always dialyze the patient. They really don't. As you said, we don't look at the creatinine, we don't look anything because they can always dialyze the patient. But when you are outpatient, when the creatinine and potassium is rising, then you need to evaluate what needs to be done because ultimately the patient belongs to you. Gulati Saab, you have a comment or shall we close this chapter?
No, I would agree with you. Well, first and foremost, as Professor Giuseppe, he said, the kidney depends on the heart. So if the heart is not going to pump the blood and collapse, the kidney would not be there. And we always have dialysis as a backup. And contrast nephropathy, I think, the pendulum is swung from one end to the other. A lot of it is being overrated. And the cardiologists again have become very good. They are using minimal doses of contrast and we have excellent contrast prophylaxis protocols. So by and large, and I think Abhijit presented an excellent case where he showed that even if the patient, went on dialysis, why bother? At least he was living.
You know what he said? Why bother when the patient is in dialysis? Jay Gopal, please.
Yeah, I just wanted to add a point. I think just want to re-emphasize the point that there is a safe limit for the renal disease. You calculate the EGFR, and if it's, let's say, 20, restrict your contract volume. I think that's what we generally follow in our cardiology practice. And today, we have all these gadgets like the IVAS and all that, where you can almost like a zero contrast, you can do cases. So I think there are a lot of things, and we are very happy that nephrologists are really supporting the cardiologists. There was a time when they used to find fault with us for doing an angiogram. Thank you.
Okay, one question for Dr. Nagular.
My comment before was just was a joke. I mean, to emphasize that nephrologists tend to be a little bit nephrocentric. and another joke I heard is that description of the heart by a nephrologist is a bladder-shaped organ.
Okay, Dr. Nagular, there is a very interesting question. Should all hypertensive patients who become pregnant or vice versa, should they receive aspirin and statin? Aspirin I heard, statin I never heard. Can you comment?
Yeah. Yes, aspirin, the data on 27,000 patients in the first trimester of pregnancy who have a high risk factor, those who have high A1C, obesity, prediabetes, insulin resistance, these are the patients who are benefited by giving aspirin therapy till term. And therefore, there is a definite role of using aspirin. The dose of aspirin used is 150 milligram, not 75 milligram. That is the dose of aspirin. There's a data on statin also, pravastatin, which was studied. The studies are still on. The recruitment will continue till 2028, and the data will come subsequently. So we don't have any data, but it is shown that statins also are protective and they have anti-angiogenic properties. They can reduce the effect of the SFLT1 and endoglobin 1. So those levels can be reduced significantly. So therefore, in the past, we always stop statin therapy in pregnancy. In the last year's American Diabetic Association meeting, there were discussion on using statins in pregnancy, how it's beneficial, how it is not harmful to the patients.
Did you say they're anti-anxiolytic?
Anti-angiogenesis.
Okay. Can I, sir? Okay, now there is a, 1 second. There is a question on salt substitute on day after tomorrow. I am going to show you some data on the anti-hypertensive effects of salt substitute due to potassium that was just published. But let's wait for day after tomorrow. Now, this is for anybody, any preventive measures against vascular dementia, I guess cardiovascular risk factor control, right? Anybody else wants to comment? Panelists, or how to prevent vascular dementia is risk factor modification, I would think.
I think the lecture we heard, is perfect. It made the point. The evidence is there, and not the best evidence in the world, but I think overall antihypertensive treatment has a protective effect. I just want to remind that we have recently published a paper from real life in Lombardy, which is the region where I live. We have a database of 10 million people, the whole Lombardy population, and we can measure adherence to drugs, including antihypertensive drugs. And what we did, we just look at whether those with better adherence to antihypertensive treatment, old people above 65 years of age, had a reduced risk of dementia. And we collected about 14,000 cases of dementia, vascular dementia and Alzheimer's disease. And indeed, there was a progressive reduction in the risk of dementia, both Alzheimer's and vascular dementia, as adherence to antihypertensive drugs increased. Of course, real life is not a trial, so there are confounding factors, but this was the data.
There, Dr. Grassi, Guido, there are two questions. One is, do you recommend treatment directed against the heart rate, number one? Number two is a very interesting question that you mentioned that heart rate is a risk factor for plaque rupture, but we advise the patients to exercise to the target heart rate. So are they at a risk of plaque rupture? Very, very nice question.
Well, the first one, I think that is obvious. For heart rate resting tachycardia, beta-blocking agents are preferred, alone or in combination with other treatment. I mentioned that if the patient is hypertensive, he or she may have angiotensin II receptor antagonists or ACE inhibitors, which may provide some reduction in blood pressure. Once, several years ago, clonidine was used, and moxonidine is still in the market, and they produce some blood pressure reduction because reduce sympathetic activation. The second question was?
You tell the patients during exercise test to reach the target heart rate. Will that cause plaque rupture if they have atherosclerosis?
So elevation, abnormal elevation in heart rate during exercise, for example, well, this is a good point because we have, but also in Italy, other people has evidence that the tachycardic, exaggerated tachycardia response to exercise may represent a link for future development of hypertension. And therefore, this is based against on the basis that sympathetic activation is something which link heart rate abnormal response to exercise to future development of hypertension.
Thank you. Dr.
May I make a comment on that? On that question?
One second. Dr. Prafulla, you asked a question of blood pressure variability. Let's hold off this till tomorrow. Tomorrow there is a topic on blood pressure variability.
Yeah, that was an intriguing question about heart rate and exercise. While we say that exercise is good, heart rate going up. So studies have shown that there is a very small increase in cardiovascular events during exercise, and there are studies showing that very strenuous exercise may also cause cardiovascular events, but that is more than offset during the period of non-exercise with a benefit. So overall, the benefit is there, despite there being a slight excess. I mean, there could be a plaque rupture at the shoulder, for example. This is also seen in hypertension. So yes, probably there is no need to advocate extreme or very vigorous exercise, but exercise, nevertheless, is beneficial and should be advised.
You know, there are always reports which you have seen of sudden death in people who are exercising. We do not know the reason for it, but there are some exercise enthusiasts who had an acute event during exercise. So we can prevent it. Muruganathan has a very brief, extremely brief comment.
No, exercise in a gradual way, it's like a physical conditioning. Somebody who has got tachycardia, by gradual exercise, his normal rate also comes down. So exercise is useful. Even the heart rate is more. Somebody who is not doing any exercise, heart rate is more. The person who starts exercising gradually, the heart rate comes down in the long run.
There are...
The same is for blood pressure. I mean, people can ask, well, you recommend exercise to lower blood pressure, but during exercise, blood pressure goes up, and in hypertensive patient, it can go beyond 200, 220. Yes, this acutely, but chronically, as you said, I mean, the benefit is there.
But during exercise, the diastolic usually comes down and the mean remains more or less the same. But yes, the point is very valid.
There were 3 or 4 questions that were addressed to Dr. Naik, but they have been answered. Namely, systolic versus diastolic limits for treatment and where to hold off on treatment. They have already been addressed at what level you want to hold off. First of all, we don't know when to hold off because patient is not in front of you all the time. So we hold off when we see them, right?
I'll have a quick comment there, sir. Okay. I said we have to individualize in every case. And one way, besides the way I look at it, besides the actual looking at his signs and symptoms, I subject all these people to a good echo with speckle tracking. And it is here, it shows us exactly whether the diastolic function has set in or no. And if the diastolic function has not set in, you can go a little bit further. So this is one marker which I routinely use. So I would say any hypertensive patient should be subjected to a good echocardiogram with speckle tracking, which shows the function of the myocardium. Because the first harm that happens to the body is the damage to the heart before he develops any other subsequent symptoms.
Thank you very much. I know Dr. Narsingan was raising his hand. I should give him a chance because if I don't give him a chance, I may not get a visa to go to Tamil Nadu. They want a separate country.
Thank you very much, sir. This is just to add some more point with respect to the question that was posed to Dr. Vijay Naglur, who talked about hypertension pregnancy. Somebody raised a question whether we can give aspirin or statin. Of course, he has identified that the study is going on. By 2028, we will be able to get some information with respect to the usage of statins in pregnancy. But what is the next alternative? For example, familial hypercholesterolemic lady becoming pregnant, at the same time the cholesterol levels are very high. How are you going to manage? I think the best drug that can be used in pregnancy complicated by the familial hypercholesterolemia, you can bring it down by using bile acid sequestrant, that is cholesevelam. Cholesevelam.
And fish oil. Okay, I think what we can do now, unless the organizers, they're coming, we are caught up. Panelists, you have been waiting. You have any comments, or our chairpersons have any comment? Otherwise, we are on time. It looks long, but it's time. Come on, Johnny. Johnny mera naam, chori mera kaam. Chalo.
Sir, just one comment can I make? Sir, just one comment can I make? Just one comment. Regarding Dr. Rajagopal, he has presented an excellent presentation on hypertension in adolescents. There, just one point I would like to add. We see a lot of female adolescent patients who have accelerated hypertension, and there the cause is aortoarteritis. And there we have to check blood pressure not in the upper limbs as well, you have to check blood pressure in lower limbs as well. So that is one of the issues that we counter in eastern part of India to rule out not only coarct, but aortoarteritis. That's the only point I would like to add.
I've seen with Dr. P.C. Rath in Hyderabad, so many patients with significant hypertension, vasculitis, really, it's amazing. So Johnny, please come and make an announcement. First of all, I want to thank all the panelists, all the speakers, all the chairpersons for conducting and concluding the meeting in a reasonably timely fashion. Johnny, thank you. We started 17 minutes late. So we have credit. We have some credit left.
Good evening, and thank you all the clinical scholars, speakers, the panelists for today. Requesting all for a group photograph, sir. Thank you all once again, and thanks for the audience also for the valuable participation and the words of wisdom were shared today. The next would be the inauguration that we have, and of course in this inauguration, every year we are grateful to World Hypertension League for the recognitions and the rewards they've been giving to the doctors here for their contribution in various fields like cardiology, medicine, and so on. So to take over the proceedings, I invite our MC for the day.
Well, of course, we have now reached to the end of our sessions for the day. Well, after such incredible presentations and our panel discussion, I'm sure we are delighted that we had so much of knowledge on the stage. A big thank you to each one of you for gracing up the stage and, of course, taking out time and joining us for the discussions. Ladies and gentlemen, I would like to mention that information about the hypertension and diabetes have been displayed around the hall. Please make sure that you visit the different zones which we have created for each one of you. So they are called as portraits on hypertension and phases of diabetes. So please make sure if you have any questions, we have the IPCA team around. You can go up and have a conversation with them. And this is an initiative work by IPCA Laboratories under the guidance of Dr. Venkata S. Ram and Dr. V. Mohan. Once again, a big thank you to all of you for joining us. But as we proceed further, we look forward to take our day ahead after such an amazing session. It's now time to move forward and officially inaugurate the Global Summit on Hypertension and Comorbidities with the lamp lighting. And as I'm sure each one of in the house would agree, the lighting of the lamp is a symbol of hope, knowledge, and prosperity. It signifies the beginning of our journey towards a brighter and a healthier future. So to do the honor, may I please request on stage Dr. Sandhya Nema. I'll request Dr. P. Sangmitra, Dr. Sonia Suresh, Dr. Jayashri Thakuria, Dr. Ishrat Kaur, Dr. Lakshmi Balkrishna, Dr. Asmita Deshmukh, Dr. Mamta Goyal, Dr. Deepika V, Dr. Manju Bansal, Dr. Subha George Thayil. I'll request all of you to please join us on the stage for the lamp lighting. All right, ladies and gentlemen, can we please have a big round of applause as we officially inaugurate the day.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya dipajyotirnamostute. Dipajyotirnamostute. Shubham kurutvam kalyanam arogyam dhanasampadah.
Thank you so much, all of you, for doing the honor. And now that we have the blessings of Almighty, of course, we are all set to take the day forward. I would request Dr. Anil Parekh from IPCA Laboratories to please join us on the stage.
Good evening, friends and colleagues. It's a great pleasure and privilege for me to welcome you all to the 6th Global Hypertension Summit with Comorbidities. And at the outset, I would like to thank our course director, Dr. Venkatram, for so many years. He has been the guiding light for us. And I have been fortunate to interact with him for last many years as a right from my postgraduate days when I was faculty at Nair Hospital. And the journey of hypertension CMEs with IPCA started when we first launched chlorthalidone. And this journey actually started right from the ALLHEAD study. The ALLHEAD study played a very pivotal role, seeing that the chlorthalidone was better than the calcium channel blockers and the AC inhibitor in many secondary outcomes. I thought that it is time to reconsider. Chlorthalidone had disappeared from the Indian market. As a resident, I have used it, but the dose was 25 and 50 milligram. That was the dose. And that led to a lot of electrolyte disturbances. And that's how the drug disappeared from the Indian market. But we thought of reintroducing it. We conceived a dose 6.25 milligram and did a series of clinical trials on chlorthalidone. And that's how the journey with hypertension started.
It's also time for me to, reflect on the international faculties over the years who have helped us in this journey. And those first is Professor Aram Chobanian, who was the chairperson of JNC 7 and was part of all JNC guidelines, right from JNC 2 to JNC 7 to JNC Z8 chairperson. So he had accepted our invitation and he came to India and we had multiple CME programs with him. Subsequently, Professor Henry Black was the next international faculty who came us. Twice he visited us in 2 years, in 2012 and 2014. And now I should call that we should pay tribute to him because he has expired last year, just late last year. So my tribute to Professor Henry Black. He was also part of the ALHET study and very, very passionate on chlorthalidone, and one of the most passionate person on chlorthalidone, I found him. And then I would also like to acknowledge Professor Franz Messerli, who has been very instrumental with us and has been associated with many CMEs doing us. And of course, we have the guidance of Professor Venkatram. IPCA has been at the fore on its own. We are at the taking part in many CMEs across. I've been associated with this company for last now 24 years. So besides chlorthalidone and my experience personally has been on chronic low-grade inflammation. And we had the first anti-inflammatory drug in type 2 diabetes approved in India, and that too in hydroxychloroquine is the first, based on our research work, it has been approved. Then we had other disease-modifying anti-rheumatic drugs studies and also studies on the anti-inflammatory NSAID drug, aceclofenac, which has been just mentioned. It is the largest selling oral NSAID in India. So I, once again, thank all of you, both international as well as our national faculties and all the delegates who have come from across the India, and wish you all a good luck and very happy learning over the remaining period. And thank you very much.
Ladies and gentlemen, we have a very important function to follow. Some of you might be wondering, with so much of availability of access to medical knowledge, why do we have this kind of a conference? If I can have the first slide, if it shows up. If not, we'll go to the... People always say, ignorance is a bliss. Don't believe it. Ignorance is always a curse. Next. This is what Mahatma Gandhi has said. The reason why we are meeting here is we should live as if we are going to die tomorrow. We should learn as if we are going to live forever. And lastly, ladies and gentlemen, there is one more slide that should come. All these deliberations we are going to have today, tomorrow, and day after tomorrow, they only have value if we are going to apply it to the benefit of the patient. And that is the important message that I wanted to give you, how we can translate such a tremendous knowledge pool and reservoir of knowledge for the next 3 days, what aspects that you could utilize for the ultimate benefit of the individual, the family, and society at large. Thank you for your attention, and we'll move with the rest part of the program.
Thank you so much, Ram sir. All right, so we were looking forward to have with us Dr. Satyendra Tiwari, but unfortunately his flight has not landed yet. But yes, it gives me an immense pleasure to welcome President, Indian Society of Hypertension, Dr. Rajiv Gupta on the stage. Ladies and gentlemen, can we please have a big round of applause for him?
Thank you very much. It's it's great to be here and to learn all the deliberations and keep on upgrading our knowledge. On behalf of the Indian Society of Hypertension, which is the largest society of hypertension experts in the country, I welcome you all to this conference. And I'm sure that the message of hypertension prevention I talked earlier in the day will reach the masses, the doctors, the public, and the healthcare bureaucrats so that we can focus more and more. Thank you very much, IPCA, for your efforts, and thank you all for being here. Thank you.
Thank you so much, sir. All right, everybody. Well, it's time to hear from the president of ESH Foundation. Can we please have a big round of applause and welcome on stage Dr. Manchia. I would also request the President ESH Scientific Council, Dr. Grassi, to please join us on the stage. We'll request you to please address everybody.
Well, Professor Grassi will say something on behalf of the European Society of Hypertension, but I would say a few words on behalf of the foundation of the European Society of Hypertension, which is made by past presidents of the society and officers, and it is mainly related to educational activity. And I just would like to thank the presidents and the scientific committee for inviting the European Society of Hypertension to participate in this wonderful meeting. It touches very important themes. Lectures today were really excellent, and even the discussion, I think, was an excellent discussion. And the other thing I would like to say is that I'm delighted to see that the collaboration between the Indian Society of Hypertension and the Indian Cardiological World and the European Society of Hypertension continues. It started a few years ago, Dr. Ram knows, and I think it has been a privilege for many of us to participate in this collaboration and this interaction, and I do hope it will continue in the future. Thank you very, very much.
Well, very few words. It's a pleasure to be here on behalf of the European Society of Hypertension. And as Professor Mancha mentioned, we have a close link between European Society of Hypertension and Indian Society of Hypertension. We had a symposium during the last meeting in Milan last year, and we hope to host again this joint meeting next year in Milan. So it's a pleasure to be here, and this meeting is very successful, so congratulations.
Thank you so much, both of you. I'm sure finally it's time to welcome on stage the man himself we all were waiting for. Ladies and gentlemen, please, if we can have a big round of applause for the Chair, Indian Organizing Committee, World Hypertension Congress 2025 and Vice President of World Hypertension League, Dr. S.N. Narsingan. I'll request you to please join us, sir.
Good evening. I am excited to be here to take part in this global summit on hypertension, where 3 important academic bodies have joined, and they have presented a lot of ideas and information about the treatment of hypertension. I must thank the European Society of Hypertension, led by Mansia and Grass, and the Indian Society of Hypertension has been taking active part in this. And I must appreciate and congratulate Dr. Venkatesh Ram, who has been instrumental to conduct continuously in an uninterrupted fashion the last 6 years. I am fortunate to be there with him all the time, all 6 meetings. And I must also thank IPCA for giving us this excellent opportunity and the platform to not only identify people with hypertension, but disseminate the knowledge in the field of hypertension. In fact, World Hypertension League has got more than 80 academic bodies under its banner. And World Heart Federation, World Stroke Federation, WASH, and then the KDIGO, all societies which are recognized, including WHO, CDC, Hearts America, all of them are actually combined in their efforts to join hands with the World Hypertension League to disseminate the knowledge in the field of hypertension. And I have been given this excellent opportunity to conduct the World Hypertension Congress in 2025, February 21st to 22nd, 23rd. It is going to happen for the first time in India, and that too in Chennai. And nearly about 33 international speakers, who is who in hypertension, they are going to be there in Chennai to take part in this meeting. European Society of Hypertension, ACC-AHA, and the International Society of Hypertension President, all of them are going to be there. I request all of you to register as early as possible. In fact, I am actually trying to put one QR code. If you just scan the QR code, you will directly enter into that and you can pay only 20,000 rupees instead of 25,000 rupees. This is only made for people who are attending Hypertension Summit under the banner of IPCA. We are giving them 5,000 rupees concession. Please make use of it. In the next 3 days only it is valid. On Monday morning, it is not going to be valid. Thank you very much, ladies and gentlemen, for patient listening.
Thank you so much, sir. Well, of course, we would like to hear from Dr. Paul Welton, President of World Hypertension League. Can we please play the AV on the screen?
Hello, dear colleagues. Greetings and good wishes. Please excuse my casual attire. I'm in South Africa on vacation with my wife, so I don't have a tie or a jacket. But anyway, I did want to say hello and speak to you in my role as the president of the World Hypertension League, and on behalf of myself and all of my colleagues in the World Hypertension League, I bring you good wishes and wish you great success in the Hypertension Summit. Now, I'm aware that the Hypertension Summit is a very popular program, and I know that this year, like other years, it has attracted more than 600 doctors from all over India to participate, and it's really an outstanding educational offering. The academic partner for the Hypertension Summit is, of course, the Indian Society of Hypertension. And I should mention the Indian Society of Hypertension is a very important member of the World Hypertension League. And Dr. Narasimhan, who is the immediate past president of the Indian Society of Hypertension, is our vice president and a wonderful colleague and friend, as is Dr. Venkataram, who has had a very long history of leadership roles in the World Hypertension League. Most recently, he was the treasurer of the World Hypertension League. So the World Hypertension League is collaborating, as you may know, with the Indian Society of Hypertension to organize our next World Hypertension Congress in Chennai this coming February. And it's the first time we will hold a World Hypertension Congress in India. We're very excited about it. India is a very appropriate place to have the Congress. And it's going to be an outstanding meeting. It's really going to be a who's who of leaders in hypertension from all over the world. And in addition to the scientific program, there will be scientific writing workshops, there will be abstracts, there will be award sessions, there will be children's art, there'll be evening sessions. It's just going to be a great program. And I hope that you will consider coming, and I look forward to personally welcoming you to the World Hypertension Congress in Chennai. So in addition, I'm aware that some of my very good and close colleagues and friends, Dr. Giuseppe Mancia and Dr. Guido Grassi will be with you this year at the Hypertension Summit. They are leaders in the European Society of Hypertension. They're outstanding scientists and they're wonderful educators, and I know you'll enjoy your time with them. So on behalf of myself and all of my colleagues in the World Hypertension League, I want to wish you a very successful summit. I hope you learn a lot, and I know you will enjoy the experience with Dr. Ram and all of his colleagues. My only regret is that I will not be there with you in person this year, but I have to attend to my wife. So I hope you'll forgive me. And I look forward to welcoming you and meeting you in person in Chennai next February. Have a great Hypertension Summit.
Such a pleasure to hear from Dr. Paul Welton. Ladies and gentlemen, finally, it's time to move towards the felicitation from WHL. And to do the honor, I'll request Ram sir to please join me. I'll request Professor Dr. Rabin Chakrabarti to please join us here on the stage. I'll request Dr. S.N. Narsingan. Dr. Manchia, please, we will request you to join us for the felicitation. Dr. Grassi, Dr. Nakul Sinha, Dr. Rajiv Gupta, Dr. H.K. Chopra, and Dr. Tiny Nair. I'll request all of you to please join us on the stage for the felicitation. All right, so it's time to proceed with the felicitation from WHL. And on that note, please, can we have a big round of applause for Dr. A.B. Mehta? Well, he's not there with us tonight, but we would request if we can have a big round of applause for him. Can we have the pleasure of having with us on stage Dr. Tarun K. Praharaj? Ladies and gentlemen, can we please have a big round of applause for Dr. Tarun? Can I have the pleasure of having Dr. I. Satyamurthy on the stage? Ladies and gentlemen, a big round of applause for him. Can we please on?
Ladies and gentlemen, we are felicitating a number of attendees who have excelled in clinical cardiology, nephrology, general medicine, preventive care, and for their adherence to the highest principles of practice of medicine and for the well-being of the society. So please join us as we felicitate these wonderful people who are just one of us. Thank you for your attention.
Ladies and gentlemen, a big round of applause for him, please. Ladies and gentlemen, let's give it up once again for Dr. I. Satyamurthy. Can I please have the pleasure of having with us on stage Dr. Sanjeev Gulati. Can we please have a big round of applause for him and let's welcome him on the stage. I'll request to all of you to please put your hands together for Dr. Sanjeev Gulati. Alright, it's time to welcome Dr. Rajiv Kumar Rajput. Ladies and gentlemen, a big round of applause for him. It's time to put your hands out there for Dr. Rajiv Kumar Rajput. Request the pleasure of having Dr. Niranjan Nishti on the stage. Ladies and gentlemen, a big round of applause for him. Everybody, please put your hands out there for Dr. Niranjan Nishti. Let's welcome on stage Dr. A. Punanand. Can we please have a big round of applause for him? Everybody, it's our pleasure to welcome on stage Dr. Lalna Bakhale. Can we please have a big round of applause for her? Everybody, let's welcome her on the stage with a big round of applause. Ladies and gentlemen, please can we have a big round of applause for her? Let's welcome Dr. Ricardo Telles on the stage next. Ladies and gentlemen, can we please make some noise? It's time to appreciate all the people coming up right here for the felicitation. Can we have the pleasure of having Dr. Rufero Montario on the stage? Everybody, please put your hands out there. Let's give a very big round of applause for him. All right, with the same energy in the house, let's welcome Dr. Guru Prasad Naik on the stage. We'll request Dr. Guru Prasad Naik to please join us on the stage. I'll request Dr. Digambar Naik to please grace the stage. Can we have a big round of applause for him? gentlemen, let's give it up for Dr. Digambar Naik. On that note, it's time to welcome on stage Dr. J.P. Tiwari. I think we can definitely increase the energy in the room. Ladies and gentlemen, can we please have a big round of applause for him? Everybody, it's time to welcome Dr. Edward De Mello. Can we have a round of applause for him and let's welcome him on the stage. Everybody, can we just hear a big round of applause for Dr. Edward De Mello. It's time to welcome Dr. Vivek Redkar on the stage. Can we please have a big round of applause as we welcome him on the stage? Thank you so much and congratulations. Ladies and gentlemen, put your hands out there for Dr. Ajay Gupta. I'll request Dr. Ajay Gupta to please join us on the stage. Let's welcome him with a big round of applause, everybody. Let's have a thunderous round of applause for Dr. Ajay Gupta. All right, so with absolute pleasure, let's welcome Dr. Amit Chhabra on the stage. Everybody, please make sure when we have them coming right here on the stage, we need to welcome them with all the energy in the house tonight. Let's welcome Dr. B.C. Joshi on the stage next. Well, we have few more names in the list, and we really look forward to see the same energy we started off with. Can we please have a round of applause once again for Dr. B.C. Joshi. Let's welcome Dr. B.D. Joshi on the stage. Everybody, please make some noise for Dr. B.D. Joshi. Can we have the pleasure of having Dr. T.R. Sirohi on the stage next? Everybody, please give it up for Dr. T.R. Sirohi. Let's welcome Dr. Amit Sharma on the stage, everybody. And he's right here. Please give it up for Dr. Amit Sharma. Can we have a big round of applause for Dr. Ashok Grover? Ladies and gentlemen, let's welcome Dr. Ashok Grover on the stage. It's time to welcome Dr. C.L. Naval on the stage next. Let's welcome Dr. C.L. Naval on the stage, everybody. Let's welcome Dr. Chandan Misra, ladies and gentlemen, with a big round of applause. Can we have a big round of applause for Dr. Dinesh Sharma? Ladies and gentlemen, let's give it up for Dr. Dinesh Sharma in recognition for setting the highest clinical and academic standard in the field of medicine. Let's welcome Dr. Imran Ahmed on the stage. So he's here for setting the highest clinical and academic standard in the field of cardiology. Let's give it up once again for Dr. Imran Ahmed. Can we have the pleasure of having Dr. K.K. Pandita on the stage next? Ladies and gentlemen, come on, can we have a round of applause and welcome Dr. K.K. Pandita on the stage. So he is receiving this recognition for setting the highest clinical and academic standard in the field of medicine. Congratulations. Let's call upon the next awardee right here, everybody. Let's give it up for Dr. Kalyan Sen Gupta. He's right here. Come on, everybody. Let's make some noise and welcome him on the stage. Congratulations. With all the energy in the room right now, let's welcome Dr. Manoj Rai in the house. Come on, everybody, a big round of applause and let's welcome him on the stage. Well, yes, for setting the highest clinical and academic standard in the field of medicine. Let's call upon Dr. N.K. Sharma on the stage with a big round of applause. Ladies and gentlemen, can we please have a big round of applause for Dr. N.K. Sharma for setting the highest clinical and academic standard in the field of medicine. Congratulations once again. And let's welcome Dr. Pritesh Punjabi on the stage next. Everybody, please can we have a round of applause for Dr. Pritesh Punjabi. It's time to welcome Dr. Rajesh Kumar Jha on the stage next. Everybody, well, he's right here. Come on, can we have a round of applause? Congratulations once again. And it's time to call upon the next awardee. Can we have a round of applause as we welcome Dr. Satish Chugh on the stage. Well, he's here for setting the highest clinical and academic standard in the field of medicine. Congratulations once again, and ladies and gentlemen, a big round of applause for him. With all the pleasure, everybody, let's call upon Dr. Vijay Kumar Garg. I think that round of applauses has to be doubled right here for him. Come on. Let's give it up for Dr. Vijay Kumar Garg. It's time to welcome Dr. Hilal Ahmed Rathor on the stage. A big round of applause for him. After this, of course, we proceed with our last but not the least awardee, and I look forward to have full energy in the house to welcome him. First of all, let's give it up for Dr. Hilal Ahmed Rathor once again, everybody. And let's welcome Dr. Santosh Kumar Agrawal. Ladies and gentlemen, a big round of applause for him. Ladies and gentlemen, a big congratulations to all the awardees. Can we please have a big round of applause for all of them? Congratulations once again. A big thank you to all our dignitaries for joining in. Ram sir, I'm sure we are delighted to have you on the stage with all the dignitaries right here. But anything you want to say to the awardees today?
All the recipients of the Felicitation Awards, on behalf of the World Hypertension League, Indian Society of Hypertension, and Asian Pacific Congress of Hypertension, and European Society of Hypertension, we want to congratulate you, and most importantly, stay the course, continue the path, stay the course to eradicate the consequences of untreated, uncontrolled, undiagnosed hypertension, and that is the best award that you can transfer it to the society back. All the best.
Thank you so much once again to all of you for joining in. Ladies and gentlemen, as we have gathered here at the Global Summit on Hypertension and Comorbidities, well, IPCA Laboratories is set to unveil 3 groundbreaking products that exemplify their commitment to the innovative pharma solutions. Well, these new offerings are the results of IPCA's unwavering dedication to research and development, leveraging the cutting-edge technologies to definitely create new therapies. For launching the first product, for unveiling the first product, I'll request Dr. Ganpati Bantwal and Dr. Sanjeev Indurkar to please join me on the stage. And meanwhile, I'll definitely request all of you to please stay back with us as we look forward to present to us, each one of you, our new products right here on the stage. We're taking only 15 minutes break. I'm sure we had such a productive day today. And later, we look forward to see each one of you for our cultural program, because it's time, I'm sure everybody agree with the fact that we are in Goa, we need to loosen ourselves a bit, so we look forward to see you all when we get the party started tonight.
This is one of the products for the first time in the country which we are launching. This is a beta-1 selective androgen receptor blocker. And of course, it's an ointment which is for the treatment of diabetic foot ulcer. The uniqueness is the phase 3 trials. Doctors showed a 60% closure of the wound when the patients came for a follow-up after 1 year. So thank you, and this is one of the novel launch that we have to the country today. Thank you.
Right here, ladies and gentlemen, a big round of applause for unveiling our second product. Of course, I'll request Dr. I. Satyamurthy and Dr. Deodatta Chafekar to please join us on the stage. So before we unveil the product, we will have a video on the screen. So before you do that, I really want everybody to please have your eyes on the stage and let's play the video. Come on everybody, a big round of applause as we present to you Suit Clip DM. Thank you so much for doing the honor. And for the next product, to unveil the next product, we'll request Professor Dr. Rabin Chakraborty to please join in and Dr. H.K. Chopra. So please, can we have the pleasure of having both of you on the stage with us? All right, so Everybody, eyes on to the screen, please. Ladies and gentlemen, come on, a big round of applause. Thank you so much for doing the honor. A big thank you, and I think I have to say congratulations to IPCA team. And if you have any queries related to any of these products, we have our team members right here. Thank you so much once again for doing the honor. So as I mentioned, we are here in Goa. It's time to have some fun and get the party started. So we look forward to, see, finally I could see the hands up in the air and the smiles back. So you need to get the energy back as well, because without the energy, without each one of you, we will not have any memories or fun tonight. So we look forward to see you all in next 10 minutes. All right, so 8:30 is what we look forward to see you all back again. And all we request is get your party shoes on and let's enjoy the evening. Thank you so much, everybody, and see you all soon. Thank you.